So good morning everyone and welcome to the second Retisurge Live. Keeping up with the new normal, this time Retisurge Live has gone virtual. Last year in the same month of March, we had dedicated our first Retisurge Live to diabetic vitrectomies with Dr. Cyrus Shroff and Dr. Shanmugam as our master surgeons. Let us revive the memories of last year before we go ahead today. So, I'm sure we all are performing the surgery for macular holes. However, there is always something we can learn from our masters. Today, we would be learning their way of performing the macular hole surgery. I have the privilege and honor of introducing Dr. Shobhit Chawla, who is our first master surgeon for the day. He is the founder of Prakash Netra Kendra Lucknow, president of Vitreoretina Society of India, one of the pioneers of modern vitreoretina surgeries in North India. He has performed live surgical sessions in various parts of India and other SAARC countries. He is also the recipient of the Reed Buckler Award and Honor Award of American Society of Retina Specialists. He's published widely and has participated in various national and international conferences. Our second master surgeon for the day is Dr. Sangeet Mittal. He is the director of VR services at Thin Eye Hospital, Jalandhar. He is known for his surgical skills, innovations, and excellent surgical videos. He has won the Best of the Show award at the annual conference of European Vitreoretina Society for 3 consecutive years. He is the first person in India to report the use of PDT for intraocular tumors like choroidal hemangioma and capillary angiomas. He was also awarded the Dr. V.T. Joshi Gold Medal for Best Fellow by Medical Research Foundation way back in '97. He is also the recipient of Dr. J.M. Pava Best Paper Award by the VRSI in 2009. Now we have a whole gamut of panelists for our first session today. My privilege again to introduce Dr. Cyrus Shroff. He's the Medical Director, Shroff Eye Center, New Delhi. He's also the advisor and a trustee at Dr. Shroff's Charity Eye Hospital. He's one of the pioneers of vitreoretina surgery in North India, especially bimanual surgery in diabetics. He has won the prestigious Reed Buckler Award at American Society of Retina Specialists. He has held prominent positions in several ophthalmic societies, including VRSI and DOS. Our second panelist for the day is Dr. H.S. Trehan. He's a senior vitreoretina consultant at Commando Hospital, Air Force, Bangalore. He's done his fellowship in vitreoretina at LVPI, Hyderabad. He's a highly skilled surgeon known for managing the most complicated trauma patients from our armed forces. We have Dr. Raja Narayanan, Director and Network Head Clinical Research at LV Prasad Eye Institute, Hyderabad, Senior Vitreoretina Consultant, and he's also the current Honorary Secretary of VRSI. He's also the recipient of the prestigious Senior Honor Award from the American Society of Retina Specialists in 2015, among many other prestigious awards to his credit. We have Dr. Vishali Gupta, a senior vitreoretina and uveitis expert from PGIMR, Chandigarh. She is the president of Uveitis Society of India and the secretary of the International Uveitis Study Group. She's the ex-scientific chairperson of VRSI. She's also known widely for her work on ocular tuberculosis through the intensive cohort study that she has published. She holds a US patent for multiplex PS-PCR. She's a member of the American Academy of Ophthalmology, the Jules Gonin Club, and the Macular Society. I will now request Dr. Lagan to please share the details of the first case. And before I give to Dr. Lagan, live surgeries, it's taking place at Dr. Shroff's Charity Eye Hospital, Daryaganj, New Delhi. And now I will join you later on from the operation theatre along with Dr. Shobhit. Over to Dr. Lagan. Enjoy the session.
A very good morning to all and a warm welcome to everyone. The first case for the day is a 61-year-old male who presented with diminution of vision in the right eye for the last 4 months. Right eye cataract surgery was done 1 month back elsewhere. So on ocular examination, left eye was essentially normal with a best-corrected visual acuity of 6/9, while the right eye, the affected eye had a visual acuity of 4/60 with a near vision less than N36. The patient is pseudophakic and has a large full-thickness macular hole. He also had a lasered peripheral retinal hole. So this is the fundus photo of the right eye showing a full-thickness macular hole. The autofluorescence of the right eye showed a hyper-autofluorescence at the foveal area surrounded by a hypo-autofluorescence. So these are the OCT parameters of the patient. It's a full-thickness macular hole with a basal diameter of 692 microns and the minimum hole diameter of 441. The macular hole index of this patient was 0.51. So now we'll be taking you to the OT and this session will be moderated by Dr. Manisha. Over to you, ma'am.
So can I, how much time before we start surgery?
Hello, everyone. I hope I'm audible. So as you can see, we have Dr. Shobhit already on the OT chair. Dr. Shobhit.
Good morning, everybody. It's a pleasure to be here. Thank you, Dr. Manisha, for having me over. So we are going to be operating a macular hole. The history seems to be short, about 2 months duration.
Yes.
And what I could examine, the patient had PVD and it's a right eye. It's a 800 micron hole, and we'll be trying to do multiple flaps. Let's see how it goes.
All the best, sir.
So Manisha, is the patient phakic or pseudophakic? I think I may have missed it.
So as you can see, we are in the operation theatre. This is our retina OT over here. And Dr. Shobhit is being assisted by Kuldeep. And we have other OT assistants. Dr. Shalin Shah, our VR fellow, is here. And we also have Sister Shaina and Sister Rani.
The patient is pseudophakic, Raja.
Thank you, sir.
So I'm asking this question basically as something maybe fellows and people who are starting out early would want to know is that, there's this lovely article published by Dr. Mahesh that surgery is more than just doing the surgery. So what are the other things that you would like to know about this patient, sir, before you take him up, besides the pure technical aspects that we've already covered? So what would we as surgeons ask the family or ask this individual before we take up for surgery?
Experience level, but you have to check the infusion. I remember my mentor's Dr. Badrinath's word, first in, last out. That's the word he used to use for the infusion. I hope I'm sure Cyrus should also remember the same. Thank you. When we are doing a macular surgery, I like to stick more towards the horizontal meridian, and I may not be following the rule of upper margin of the lateral and medial rectus.
Shobhit, you mentioned that there was a PVD, what we often find
So
irrespective
it's a
of what
25 gauge vitrectomy.
5 gauge width. I feel more comfortable with this, unlike my friend Sangeet, who does nearly, I think, 90% 27 gauge vitrectomies now. Somehow I've loved this instrumentation, and I feel the purchase of the forceps is much better with the 25 gauge in my hands when I compare it to the 27 when we are looking at purchasing the edge of a membrane or the ILM.
Yeah, I think we are on the same wavelength, Shobhit. I think we also do almost all 25.
Yeah, I find the 27 tends to hold a very small part of the membrane, and the membrane tries to fragment along that edge.
And using the cutters becomes an issue. You know, in our setup,
I'll just request everyone to post their question and answer questions on the Q&A box. We'll take them up after we have finished with the surgery during the panel discussion.
There's the wise ring there. Way back at a meeting, I think Dr. Manisha was also there. Dr. Cyrus and Dr. Sangeet were also there. Dr. Claus Eckard had presented around 10 years back cases of macular hole, where he had discussed, and later it was published also, air versus gas for macular hole surgery. So in that series, he had pointed out that a good peripheral vitrectomy, not necessarily a base excision, but a reasonable peripheral vitrectomy, leads to better surface tension apposition of the bubble to the hole. And that's why he had advocated better results in those air-filled eyes which he had done, where he had done peripheral vitrectomy also. But later on, he gave up the air-filled technique and stuck to 20% sulfur hexafluoride only. This was way back, and the results have been published. It's in PubMed, this paper. So that's a retinal break there with well-done laser. So a reasonable vitrectomy. Till the posterior, well, there's no attachment here. It's detached reasonably till the periphery, the vitreous here, as you can see. In our recent experience with macular holes, focus करें, with doing more and more cases of macular hole, we have been seeing a lot of lamellar hole associated macular proliferation, even in full thickness macular hole cases. It's like a fleshy hyaline membrane, and we've been identifying and making recordings of it. And also my fellows are keeping track as to number of the cases where we are encountering it, just to see, study, and maybe send in a report. Can you focus a little bit more?
So which lens are you using right now?
Manisha, can you hear us?
So I just want to tell everyone that Dr. Shobhit right can't hear anybody else. So maybe we can store the questions that you have in your mind. We can put them up to Dr. Shobhit later on. As far as the lens is concerned, we are using the Resight system of viewing, and we are using the Constellation vitrectomy system. And it's a 25 gauge vitrectomy.
I don't use any visco. BBG has shown in various studies, or there are a few anecdotal reports from 2 or 3 Indian groups who've shown, but by and large, BBG has shown no toxicity to the RP and to the retina, and even to the Mueller cell or the ganglion cell layer in short exposures and in routine surgical peeling. It's only when repeated 4 or 5 times you repeat the BBG and you keep it for very long time, then it is. I normally stain for about 20 seconds. Okay, 20 seconds over. Just remove the residual BBG. Light percentage कितना?
So currently the wide angle lens only is being used of Resight. It's only later on during the ILM peel, Dr. Shobhit plans to use a dog contact lens. But right now we are using the Resight.
Okay. Can I have the dark lens now? Change that to invert.
So now the inverter has been switched off. And the dock contact lens is being placed.
अभी देखते हैं. So that's what I like to use for my peeling.
So what makes you prefer this lens over the Macular?
It gives me a much better depth perception. I have found that I am able to do a less traumatic peeling with this lens. I'm using a different handle which I'm not used to. I normally use the tips on a metal handle. I find that more balanced, but this also seems good.
So another question is that you're planning an inverted flap. So how do you decide?
About what?
There's another question, Shobhit sir, that are you planning an inverted flap for this patient?
I'm planning multiple inverted flaps, which I like to do. The only thing you have with this lens is that the assistant has to keep on rolling it to be straight a little. It requires a little assistance.
And where do you plan to start peeling?
Always the inferior, near the inferior arcade. I first try to do a pinch.
Shobhit sir, if we could just center it a little. Yeah, much better. Thank you. So as you mentioned at the start of the surgery.
You see there is a little ERM type formation also here where there is negative staining. And I've got one small flap from the inferior end on the hole. Then I go in for the temporal peel. You see, I would not be sure that this is not LH. This is not lamellar hole associated epimacular. If you see this fleshy membrane here, we've been recognizing this in more and more cases. And I don't think these are ERMs. According to the literature, there is a pretty high incidence of this epimacular proliferation. And you can use it to your advantage for even covering the holes. So there goes my second flap. Now this is something I'm very keen about always. I like to do a healthy temporal peel. As you're seeing, when you're in a new setup, your ergonomics is slightly different. You're adjusting to the chair. You see this, where lifting this from here, you're relieving the traction along the temporal raphe, which I feel is very important for higher closure rates. And this has been, I've been looking for publications on this part. I found a lot of publications on deciding and customizing the peel according to various softwares and other things, but I've not found any publication which says that the temporal raphe, but it's important to relieve this. And there this goes. So I will bring a small peel from here also, and then do my nasal peel. And there goes my last flap. So it's like an envelope. So I have plenty of flaps covering this hole, as you can see. Must thank my assistant for, I think he's using this lens for the first time, but he's doing a very good job by keeping things in excellent focus for me.
So Dr. Shobhit, I have a few questions for you that beginners struggle in the initiation of flap. How do you judge the depth of hole with the forceps?
I close the forceps once or twice next to the blood vessel, and that many times causes a breach in the ileum. Otherwise, a better way is to use the Fennis loop, which makes things very simple. Just give me a minute, then I'll answer. Let me just do a
I don't know right now if the pulse rate of Dr. Shobhit is higher or mine is higher.
I'm quite okay. I feel today macular hole surgery center ka diyega lens. Thank you very much. See how much, as soon as this contact lens is centered, how well. I'm happy with this much peel now. For me, this is okay. I think this much is okay. It's quite relaxed. You see, the retina is good. Looks fine to me.
Do you recommend switching off the infusion, for keeping the flaps in place?
No, I will now change and I will start my fluid air exchange from the anterior, just in the retro pseudophacos area, and go back. And you will see it will be all very nice. I don't use visco at all, though my friends use visco, 1 drop of visco, but I don't. But if anybody wants to use, there's no harm in using 1 drop of visco, but I don't feel the need. Hopefully it should go very well without anything. Can I have the recite?
We are shifting to the recite again. And so before you go ahead with your fluid air exchange, there is a question that when we use inverted flap, can we reduce the extent of the ILM field?
Yes, we can. But this was a big hole and I wanted to relax the temporal raphe. You see the look of the retina when I've, the zipper effect. You see, ILM is not like, I can't see. बीच में वो ठीक से नहीं लगा, बीच में अटका है। ये आपका जो है ना, can I have the table a little higher, बस थोड़े सा और ऊपर करने के लिए टेबल को थोड़ा और ऊपर कर, बस बस perfect. Can I have the
Do you really check the edges of the hole that the flaps have come right till there, sir? Do you check the edges of the hole that the flaps have come right till the edge?
Yes, that's what I was doing. I have brought it absolutely to the edge, just keeping it hinged enough so that I don't lose it and it doesn't get avulsed. Otherwise, it's okay.
And do you do
way of putting एक वो डालिए इसके ऊपर 25 gauge cannula. I'll show you a very important tip when your set is new and the valves are good. So you just slip on a 25 gauge cannula on top, the port cannula, and then you negotiate it through that. That is what I normally use.
That's an important tip, sir.
So you don't need to even change from recite to and go. बिना valve का। like a jack which will keep on going up and down. वो मैं कर दूंगा. Now the surgeon can, where have you dropped it? Acha. No, that I'll do, don't worry. The surgeon can shift this here himself. No, I don't need the reciter.
So this
So
is
this is-
basically to negotiate the soft tip through the band cannula, sir.
Please invert. Yes. See? In a minute, please invert. Yeah. And there it goes. That's how I work on this. Active suction on. Kitta, what is the suction like?
So a soft tip 25 gauge flute is being used and it is connected to the active suction.
The FG should be on. That's because I was not in my setup. I made this miss 30. So first do the anterior. Kindly focus a little bit. The other way. Thank you.
So we are currently using a vacuum of 380.
That's perfect. You see the flaps coming onto the hole. So that's how I like to do it. And I'm not using the full vacuum. I'm just keeping it partially depressed. Can you now put it to passive?
Just disconnect.
No, don't disconnect. Just increase the FG pressure to 45 for a second. So in the last step, I don't want active suction pulling on the flaps. So I just go this way.
Any tips to be avoiding your inadvertent suction of the
Yes,
flaps? Sir?
keep at the disc or very temporal at the raphe if you want to, wherever you're seeing fluid, and switch to passive at the end. You can even go up to 50 for momentary.
So you actually prefer the temporal edge of the disc for this, sir? Because
Yes.
otherwise people recommend keeping it on the
Nasal
nasal.
also and temporal. I do both.
Right.
I am quite satisfied. See the coverage of. Can you focus a little bit more, please? No, the other way around. See, it's got a good coverage here. I didn't even need to trim these flaps. They are not very huge.
Put your light by a little back. Yeah, now it's much clearer, sir.
Good. I didn't use a chandelier because this was not a myopic eye. Otherwise, just for a demo, I would use a chandelier and not also. But you can see it. See.
So for a
This is not passive. I'm not using any active. Now I used active a little. With passive, there is no danger of, in the end, for the last. In fact, I've blocked this and I'm very close now.
apparently, sir, the staining of the ILM was not very uniform.
No, it was not.
Yeah.
That was lamellar hole associated epimacular proliferation, I felt. But not too much of it, but there was definitely along the temporal rim and mostly around the temporal rim and a little bit around the nasal rim of the hole.
Would you recommend a longer staining time if you're doing a myopic eye?
Yes, 30 seconds at least.
Right.
And I like to put a chandelier and also use that. And there I think this lens, a contact lens, works beautifully. We can remove this.
So for those who could not hear it properly, Dr. Shobhit recommended using the dye for about 30 seconds and also using a chandelier while operating the myopic eyes. Any other tips, sir?
If you can, when you're using the resight system, before starting use for any macular surgery, go to medium to high magnification and focus your microscope to the limbus nicely, and then start using the resight. You will do very less manipulation and adjustments. And the best thing to have, can I have the forceps, is to have the, do you have a metal tip ball? Yes, you have. This is what I need. So my technique of removing these cannulas is this. I'll put, can you please decrease to 20? 25, the pressure 25. Air pressure 25, please. So I like to do this technique, and I like to use a firm instrument like a ball. Make it 30, please, for a second. And I keep it there. And normally there's no leakage. But you have to be patient. You should give it a minute. There's no need to hurry up. I will be doing my fluid air exchange, gas air exchange in a different manner. I'll just show that to you. So after we've done this, I'm satisfied with the closure here. Can I have the light pipe, please?
So Dr. Vishali has a question, sir, that the epiretinal proliferation, why do we say it's associated only with a lamellar, or you can have that with
yes,
a...
that's what I'm saying. We are noticing in more and more, and that's what the literature has also reported, and that is what is our experience. We are seeing it in more and more. The name is lamellar hole epimacular, but I say it's a macular hole epimacular proliferation, associated epimacular proliferation. See, the ceiling is good. All I had done was a little displacement of the conjunctiva and a mild inclination, which I don't like to measure in degrees. It's measured in comfort rather than in degrees, and you get a very good self-seal with 25 gauge. So that has somehow obviated the need for, 27 gauge for me. I'm happy. So this is how I do it. Again, wait for a minute. Don't be in a hurry. Can I have my...
So for those who are wondering that what is this instrument being used, it's just a regular depressor, the straight depressor.
Pleural depressor, yeah. One drop of visco on the cornea. So normally I use one with the silicone here for better control, but I'm using a regular flute here, what they have. And you measure about 3.5. Can I have a 3.5 measurement, please? Can you just show it here? Okay. Can you? Yes. After that, I just keep my tip of the needle here. It's a 26 gauge needle. And he's connected a 20% SF6 mixture on a 50 cc syringe, 10 ml of gas, 40 ml of, yes, please. And when last 5 cc is left, let me know, please. So this is how I like to do. I find this more regulated, this exchange, and mostly on the 5th day, you are able to do an OCT in these patients. With the gas I'm using, that is what I've been seeing. On the 5th day or the 4th day, it's clear of the fovea, and you're able to see in the early post-op phase your whole closure.
Would you recommend checking the periphery, sir, after the fluid?
Of course. No, not after the fluid exchange. I have checked it during my surgery. There were holes which were well lasered. I showed you. I normally do it before. I do it after FG on the table. but not after gas exchange. Yes, after FG, of course, because your view is much better. You're able to see right up to the aura. 40 ml gone. So I come out with this. That's a fair exchange. Can I have the forza? Please push some. I check the pressure. No, it's a little high. Just withdraw a little bit. But that's it. Little bit.
So right now the air is off and the air is being exchanged with gas.
Yes. And that's it. So I have a pressure here of about 12 to 14, which is okay for me. I have not measured it, but that's what I assume. It's about 14 to 15. So that's how I like to do. Do you like to give some subconjunctival steroid or antibiotic? No. Okay. Just put some gatifloxacin or moxie, whatever you have, and 1 drop of cyclogel. I always like to use 1 drop of cytocort or cyclogel, but I feel patients' post-operative period is much more comfortable with that.
That was a quick surgery, sir.
Thank you very much.
I wish we had planned it as short as what you made us see.
Excellent surgery, Shobhit. Really great.
Thank you very much.
Yeah, excellent surgery, sir. Excellent surgery.
So thank you, Dr. Shobhit. I think that was a wonderful surgery. And now we will be heading for the panel discussion.
Hello, may I audible?
Yes, you're audible.
Am I audible? What's it?
Yeah.
Yes, Manisha.
Yes, sir. So I think Dr. Shobhit will just join us in a minute, and then probably we can take up the remaining questions to him.
You're here in Delhi?
I'll be just taking up a few questions, sir, which have been posted in the chat box.
Yeah.
What is the technique of staining in a macular hole with retinal detachment for you?
Macular hole with retinal detachment.
Yes, sir.
I like to again make flaps. I use perfluorocarbon liquid, and many times if there is not much PVR, I leave these cases with gas and they do very well. I find that the closure pattern is beautiful even in those cases. Only difference is there I use 15 or 17% C3F8 and not SF6. Good morning, Hemant. Good morning, Vishali ma'am. Good morning, Raja.
Surgery, sir. So nice to see that. Really nice.
If I can add a little thing for the beginners. Excellent surgery, Sangeet.
Thank you very much. Thank you.
Wonderful. Macular hole detachment, if you see the detachment extending up to the aura, please look for another break
Yes.
other than the macular hole, because macular hole detachment per se will never extend up to the aura.
And normally the pure macular hole detachments, normally with the new flap technique, are not so difficult to treat. The whole problem becomes a problem when there is a staphyloma. And the break is at the edge of the staphyloma many times. So it's not truly a macular hole, but a break at the edge of the staphyloma in a myopic eyes. Those eyes are more challenging. And somehow still gas works better, but you have to flap those holes also. You cannot just flap not only a macular hole, otherwise that will 100% open up because you're not doing any retinopexy there.
And how about autologous retina thing there?
I have not used autologous retina, but I have used free ILM flaps. But I have always used it in conjunction to PRP in a failed surgery. I like to do where you are re-entering an eye for a failure, it's always better to combine it with a platelet-rich plasma along with a free graft. I feel just leaving it on the basis of one, I have seen many times my ILM shifting from the macular hole when it's a free ILM flap. So free ILM flap, you bring it under PFCL, you put it there, you do everything, but it can move because it's a free flap. So it's always a good idea to put platelet-rich plasma, and if you're not able to do platelet-rich plasma, just decant a syringe and put serum. But nowadays I do platelet-rich plasma because it's very easy for us to just inform and the machine comes and in half an hour they prepare it for us.
Have you tried AMG, Shobhit?
I tried it, but I tried it in optic pit with associated not only schisis but also macular hole. And I found it, I left it there. I've done two cases, one of a chronic hole, which was a failure, large hole, and this in the this optic pit case did well, but I found no difference from my flap technique. In optic pit, what I feel is a good thing is to do a 4 flap foveal reinforcement and 1 flap covering the pit, and all are hinged. So you're doing a foveal reinforcement surgery also there with your ILM. So when the thing settles around, there is no chance of a macular hole forming. In contrast to what we used to do earlier, and we used to burn our fingers at time, that is do a non-foveal sparing, but now you do a foveal flap. So not only it's a foveal sparing, but it's a foveal reinforcement, which I feel is important in these cases. AMG, in the chronic hole I did, I found that my membrane had shifted and my hole had become smaller, secondary closure, but it had not closed. I find handling the membrane difficult.
Dr. Shobhit, what would be your take on sparing the papillary macular bundle as much? Like you said, temporal retina we all see is much more taut, and whatever the epiretinal proliferation that we have is mostly temporary. Somehow we don't see that so much nasally.
So ma'am, that is just what I've been thinking in my mind and talking to my fellows, that let us just start doing a temporal raphe relaxation peel and 1 temporal flap, and that's it. There is no need for a nasal of traumatizing the papillomacular area at all.
So actually, that was my point, that when you were doing a fluid air exchange, it's the temporal flap which inverts into the hole because of the fluid current. The fluid current actually everts the nasal flap out of. And often, if you don't tuck it, majority of the times you'll find that the flap is out actually. It's
So Hemant, I have not found that a problem. Tucking has never been something I have been very hot on because I feel it's far more traumatic. But I find that I normally do an OCT on the 5th day and I find that the flaps are in place. And many times the hole is also closed.
In fact, we do the OCT, in fact, the next day only in most of these cases with the swept source, and we find that the hole is closed and the flaps are in place. So I don't really think you have to worry too much about the position of the flaps. I think they find their place.
So that's because the temporal flap has covered the entire hole. The nasal will not see because it is attached to the retina. That's the thing.
I think Hemant
as well. It works just like a pure temporal peel and works beautifully, I think.
I would like to ask Dr. Vishali one question. In nearly 30% cases, I am seeing what we call as lamellar hole epimacular proliferation, but it's in full thickness macular holes. What is the exact pathology behind it? I have been reviewing the literature, but the exact cause I have not been able to find. It says, is it a vitreoretinal interface fibrosis, or these cells are from the Muller cells only from the island?
It's more likely to be from the vitreoretinal interface because that is why probably your hole is large. And these vitreous things, they act as a tangential or expanding forces, and that is how. So I think one of the logic of removing the ILM is when you have removed the ILM, you mean you have removed everything on top of it. But it would be a good idea just to take one flap out with 27G and do electron microscopy to see what exactly that particular tissue is made up of.
Yeah, because the literature says all membranes are because of the friction at the vitreoretinal interface at the macula, because of movements, head movements, body movements. So I was just wondering, is this different? Because the look and the consistency is very different from an ERM.
It looks like the condensed is along with it. You can make out that transparency.
Yeah, the minute you are peeling, you know it's not an ERM.
No, it's not membrane. True.
It has a different elasticity somewhere between the ILM and an ERM.
Yes.
Somewhere like that. It's like a very stretchy ILM for all, and very it tends to wrinkle much more than an ILM and much less than an ERM for some reason. I don't know if I'm explaining it right.
But most of the surgeons are using it to their advantage and covering the hole with it.
Because it gives some substance to the flap.
Yeah, like
exactly.
It gives some substance to that flap.
Because amniotic membrane is also just giving a basement membrane, some stroma, and some collagen.
Absolutely.
And a substrate.
Yeah, because if you try to remove that entire epiretinal membrane or whatever you call it, epiretinal proliferation, then what's going to happen is that your inverted flap will get aborted actually, because you will really remove the ILM along with it around.
Correct. You're absolutely
right. That you have to be careful if you're planning an inverted flap, not to kind of do a big peel of that area and get to the ILM itself.
And I think one good key for the beginners, what Dr. Shobhit said is when you are doing fluid gas exchange, just do not go all the way to the disc and start. Stay at the interface, like you showed it beautifully in the retrolenticular place, and then gradually at the interface. And when you are going to disc, stay away, go on the nasal side. I think that would be very helpful for the beginners.
Ma'am, I find that also obviates the need of a retinotomy in many pseudophakic RDs when we are doing vitrectomy if we start from the anterior. We can go to the peripheral break many times and do adequate drainage, leaving a thin amount of fluid behind, and then the job is over actually.
Yeah, that doesn't matter. The next stage.
This fluid exchange technique actually becomes much more important and requires much more finesse when you're doing a pre-ILM flap. Because here the flaps don't come into your cannula even when you're at the disc. They just evert or invert. But when it's a free ILM flap, you may be at the nasal part of the disc. If your pressure is 40 and you put, by chance, you forget that the pressure is 30 or 40 and you put your flute at the disc, the free ILM flap will jump out of the hole and go to your flute. So at that time, in the last bit, I make my FAE I make the pressure differential low. So that it's a very gradual from the end of the disc. It's about 20, 25, maybe even sometimes less than that. And it's a very gradual drying. Otherwise, the ILM is floating actually on a very thin layer of fluid. The minute that layer gets disturbed, it comes, and in the blink of an eye, it's in your flute needle. Have you had the same experience? Do you do it in the same way or something else?
I do it the same way, but I use in the end passive.
I do passive.
I don't do passive in the beginning.
No, I don't do passive.
80% of the vitreous cavity is air filled when I turn from active to passive.
Correct. So
what do you find is the advantage of the method you described of injecting through a needle and extruding through the infusion rather than connecting the gas mixture to the infusion and letting the air go out through the needle?
I think it's a more complete exchange, and your gas fill is better. It's a very and even if you can leave a lower pressure in this technique, I find this technique much better because somehow I feel, though I many times do it with the soft tip and I slide on the cannula in the end and then put the ball tip, but I feel this technique, the gas, from my experience in pseudophakic detachment eyes, the C3F8 mixture remains in much longer. So I assume it's a much.
Is your the infusion is it clamped or is it open? Because otherwise there could be air flowing.
No, I keep it. I just keep it on the syringe, and I ask my assistant last 5 cc just to keep a minimal pressure, as if there is flow, and I pull it out with one jerk.
No, I'm meaning the infusion cannula, which is still there.
Yes, I'm talking about that only.
Okay.
So that has a positive pressure when I'm pulling it out.
So then
that whole system has a positive pressure.
No, where is the outlet when you are doing the exchange?
It's connected to the 50 cc syringe through the tri-way.
No, that your needle is connected, no?
No, not needle. The infusion port. The gas is coming through the infusion port.
Okay,
so
that's how we also do it. I was wondering.
Yeah, needle is just the exclusion.
Yeah. Okay.
That clears the confusion.
Because used with the needle you had put in the end.
Yeah, that was just a Charles flute needle. Nothing else, with a 26 gauge needle attached to it. Charles flute handle.
Right. So that's how we also do it. I was wondering why it was being done the
I
other
normally
way.
do it with the dog type with the silicone in between, because you're able to regulate the pressure better. But this works equally well.
But sir, I actually thought you were doing it the other way, that you were injecting the gas through the 26 gauge and you were allowing the air to exit through a low pressure FAE. And I found that would be a really interesting thing to do, because even if your infusion port leaks after you remove it, you've got a gas-filled syringe in your hand. So that's a great advantage to maintain pressure in the eye.
No, but the air could be diluting the gas also. So I mean,
yes, that's a little bit uncontrolled. What I've seen other people do also is that they have a gas-filled eye and they inject 0.3 ml of undiluted gas or pure gas, and they're happy with that too. And they say it achieves the same concentration.
Now, Dr. Shobhit, is there any situation, say the hole is at borderline 400 micron, 300 micron, would you do a simple ILM peel without a flap or without any?
Even in pinpoint holes, I'm tempted to do a small single flap now, because I don't want to do a repeat surgery.
Okay.
It's, in my hand, I feel that the flap works very well. And even in a 200 micron hole, I like to flap it.
And the same question is, like, you're doing a pinpoint hole and you have put a flap, the flap is going to be bigger. Let's not say pinpoint, let's say 300 micron or 250. So what, would you like to tell our youngsters watching it, the tips and tricks of trimming the extra part of the flap?
Well, what I normally do, I keep a suction of 50 only. I bring down my cut rate to 2000, and the suction is also linear, but the cut rate is not linear, and I'm able to trim. I've never had a problem with this technique, and you just adequately trim the flap. That's it. It works beautifully. This setting, you can even take it up to 100, but not more than 100.
I think Dr. Unnikrishnan wanted to make a comment. Uni, if you could add.
Thank you, Dr. Manisha. Just 2 points. One about the gas injection. Like Trehan said, I inject gas through the active port. Okay. And we lower the pressure on the machine decrementally. We start at 15, take it down to 10 to 5. And by the time the last 10 cc goes in, the injection is nearly complete. Now, this was very easy when you had the non-valve systems, because the gas would be exiting through the active port and also into the machine. When you have the valve systems, I just put a 30 gauge cannula through the other port so that you have a minimal egress and the pressure never goes up. So that's we use what Trehan said. We use the very low FAE on the other side. And what happens when the volume is being replaced about 50 times because we use a 50 cc syringe. So what happens is that there is an equilibrium forming inside the system. So when you take it out, you just have to raise the pressure to about 20, and the assumption is that the gas is nearly of an equilibrated form. The second point is about the LHEP. We have a paper which has been accepted about LHEP's secondarily closing an ectopic macular hole after the macular hole got closed. So it is a reproliferative tissue essentially. And there's a wonderful histopathology paper just comparing LHEP with ERMs. The main difference is the contractile elements. The LHEP contractile, it does not contain as many myocytes and contractile elements as an ERM, which by itself can, let us interpret that the metaplasia into fibroblasts that happens in an epiretinal membrane, the RP change metaplasia into fibroblast is not exactly there when the tissue is an LHEP. And that is probably why LHEPs have this smooth surface on imaging rather than a wrinkled surface, which is a secondary to the contractile features. Thank you.
Thanks, Uni. I think those were wonderful tips. I'll request Dr. Mahesh also. I think he's wanting to make a few comments.
Yeah.
Hi, Manisha. Dr. Shobhit, wonderful surgery. Enjoyed it.
Thank you.
Thank you.
Thank you.
I did make those comments on the chat, like LHEP, the best way to is to stuff it inside, and LHEP, the better that the diagnosis is made prior to the surgery, so that we are prepared for it. We peel it and stuff it inside. That gives better visual results than trying to remove it. That's not a great idea. And there are multiple studies where they have shown that peeling it and stuffing it inside gives better results. And there's another modified technique where they have peeled the superior ILM and draped it over, covering that stuffed LHEP that's supposed to keep the LHEP in place. That study also, they have shown good results. Other than that, for the inverse flap, one other technique which one of my colleagues had suggested is you peel the ILM, then trim it before we peel it up to the edge. So leave about 1 diameter of the ILM unpeeled, so you can like trim it without the risk of peeling the rest off. And that little island, you can peel it subsequently towards the edge. That way we won't lose the ILM like accidentally when we try to suck it.
There's also very recently ophthalmology retina a study of 9 eyes where they could close the hole with topical diflupred in 90%, the small holes.
Three drugs. They use 3 drugs. Yeah. Diflupred, they use
Dorzolamide,
Dorzox,
and
MSAD.
I mean, this is too high for spontaneous closure. Like we all talk about spontaneous closure, but 90% getting closed is a bit too much. So
it's just 200 micron holes.
Yeah.
Small holes. Yeah.
Patient.
So probably it's a good idea to try some of these tricks. I don't know.
What about a 200 micron hole with and without PVD? Which do you think will have a better closure rate?
I think if there is a PVD, if there is incomplete PVD and you can see traction, I would just go in and take it out. You're just tempted to do it.
Yeah.
No, your conscience doesn't allow you to give drops.
And if there's PVD, can we think of something else or just wait and watch or do a surgery?
I don't know. I have never tried these drops and I haven't read this paper in detail, to be very honest with you. And I don't think it's randomized. But if it is a complete PVD, maybe, I don't know. To be very honest, I would still go in.
Yeah, we all do. Because patient is complaining of a recent drop of vision.
Absolutely.
Dr. Shobhit, tips for people starting out.
On what? On macular surgery or?
On macular hole. On macular hole, a plain simple macular hole ILM peeling. Why do you
should
start?
Always use a Fennes loop to initiate.
No, why do you start inferior? Like you always start inferior. Why do you start inferior? How do you ensure great focus and depth? And how do you ensure stability?
First, I would say the positioning of the ports is very important. Okay. More near the midline, which gives you much better access and purchase of the membrane rather than one which is situated more towards the superior. And so both the ports can be nearly 170 degrees apart, and that's very comfortable. So the other point I say, because it's always easier to access the inferior arcade, and you're able, and always use a contact lens when initiating the peel. I have tried all sorts of macular lens. I've even tried the new Oculus lens, which gives you complete magnification all through. That's very good. On the reside, it's an Oculus lens for the reside. But I feel the depth which you get and the least traumatic peel which you can do on a good quality contact lens is excellent. Second, when you bring the flap up towards the edge, Mahesh, I think, likes to keep it more away from the edge. I leave a lesser area between the edge and the flap, and then go in for the temporal grasp and do a nice temporal raphe peel. While you are doing the temporal peel, you will find many times you are able to leave a sliver which is enough to create a temporal flap there. And then you can complete your peel. It's up to you whether you want to peel across the maculopapular bundle or not. I think it's a very good idea just to avoid, because there's not much traction mostly there. But if you're seeing an ERM and thick proliferation on that side, then I would be tempted to peel that area, which I normally do. And then lastly, the superior. And then after you've left the flaps, go in for the leftover and enlarge your total ILMP.
If I might add, another advantage for the beginner is that when you are going inferior, you have a kind of an angulation. And with that angulation, when you are making that initial pinch, you are always seeing the retina. And secondly, this concept actually came from Payman, who said you should pinch it in the inferior, because even if you create a break, the scotoma will be in the superior half. I don't think with the modern instrumentation, to be very honest, we are causing the breaks, because 20G was a different thing altogether. But to me, that angulation for the beginners would be very helpful.
So it's a very convenient, natural angulation. Your forceps naturally goes towards that. And if you start from superior, you have to kind of apply a superior force. And that causes your hand to be that much more unstable. That's what most of us will start from the inferior or inferior temporal.
If we have time, what is the view of the panel on how much vitrectomy to do for a macular hole?
I was going to ask that next. What is your landmark that now I have done enough? Because I do more. I've seen people who do much less, and I feel maybe I'm overdoing this. So when a person starts these surgeries, what is it? What should be his landmark that, okay, I've seen this now, I should stop here?
There is only one mention of this in one paper of Dr. Eckhart, which I said, air versus gas, but that is not of relevance because he himself has also stopped air. It's now only gas. So in that he had said when he was doing a better removal of the vitreous, not base excision, but a better removal till the base, he was finding that the apposition, the surface tension created by the larger bubble on the hole was better, surface tension effect of the contour of the bubble onto the hole. So, but when it was given up, there is no other mention which I have come across in the literature. I was looking at this point, in fact, yesterday, only to raise this point and try and seek an answer for this.
Absolutely right, Dr. Shobhit, that Eckhart's paper. If you leave a lot of peripheral skirt of vitreous, like post-equatorial, you see next day the air bubble is just, gas bubble is just 50%. So to do a good exchange, you at least go as comfortably, we tell our fellows as comfortably you can, but at least equator and beyond, don't go up to vitreous base or all, but it should be reasonably to have a good gas fill which can cause the tamponade.
So no need for depression, go do a good vitrectomy without depression.
If the eye is phakic without bumping the lens.
Yeah, but we always combine these surgeries. So
Yeah,
most of the eyes are
most of the
pseudophakic
time,
unless
yes,
the patient is very
sometimes
young.
one does do it without that also.
Yeah. So what is your, suppose you have a 40-year-old with a macular hole versus the 60-year-old with a macular hole, both clear lenses. Will your decision change? What would you do?
Yeah, I mean, I would do phaco for that patient.
For which patient?
60-year-old phaco, a 40-year-old just do a macular hole surgery.
So I'll just take up a few questions if you people would allow. I have a lot of questions posted on the Q&A box. So one is from Ribu Soni, that role of simple gas injection for closing macular holes. Any thoughts on that without doing a vitrectomy?
Not bad. Only simple gas injection.
No.
That was a simple one.
The question is why?
Especially in a myopic eye, you can create a break. I have created in the days of pneumoretinopexy an opposite quadrant break in a myopic eye, and I have seen it. From that day, I have given up pneumoretinopexy as a surgery.
You all gave up.
And another question is, sir, that some surgeons, they just inject a 0.5 cc full percentage of the gas at the end of the procedure. Any thoughts on that? Like a pneumatic kind of a procedure, just putting in 100%.
In an air-filled eye.
Yes.
In an air-filled eye, yeah, that's what I was mentioning. Some people just inject undiluted gas, 0.3 to 0.5, and they believe that the antibiotic dilution you get is as good as any. Now, there are definite advantages to this technique, and it seems to work reliably for them. I haven't tried it, I haven't had guts to, but some colleagues of mine do it. And if it works, it's a really great technique, because then all the problems with leakage and trying, if there's a leakage from the port, then you need to go in again and inject. So all that gets taken care of, actually. So if somebody can say that it works reliably and every time, I would switch my technique.
I think in our initial career, even Dr. Cyrus and I have done it in a few cases, but there were surprises of pressure eyes.
Absolutely, because it's not very
controlled.
It's
the concentration is not.
May have surprise next day.
Yeah, I personally don't do it.
No, not at all. I remember in those cylinder days when we had those big cylinders, Cyrus, we used to do when gas was not so freely available in cans. I'm talking of 25 years from now. We did a few cases, and there were surprises where there was increased pressure.
And how big were the cylinders, Dr. Shobhit?
They were about the size of a 1 pound cylinder.
Okay.
And they had a regulator on top. They had a catheter system to remove the gas.
Yes.
I have a question in specific, Dr. Shobhit, for you, since you are a fan of combined surgeries. So in a post-phaco macular hole surgery, when does one intervene if one has an optic capture after surgery?
If one has an optic capture after surgery?
This is a question posted by Dr. Gujral.
I don't think there is any issue. You can always manage the optic capture very well. You just do it right there and then or the next day. Why should you wait? And if you feel like, you can do a small PI also, though it's not a very good idea to have and put air in the anterior chamber, not gas, because gas mixture is more toxic to the endothelium. But nowadays, a lot of corneal surgeons are using the gas mixture for detached decimates also. So I don't see any harm. You can just do it. I would not like to wait.
And Dr.
When it is detected, it should be taken care of.
Now, have we understood the question correctly? I think maybe he's asking if you have a optic capture and there's gas in the posterior chamber. And the gas in the vitreous, the minute you go in, the AC is going to collapse.
But no, you can remove a little bit of the gas and you can do it. You have to do it. You should not leave it.
So Dr. Shobhit, Dr. Ajay apparently made a comment that he saw you rubbing, just pressing the sclerotomy sites with the knob, metallic knob, rather than rubbing it over there. So any specific reason for
That's good enough. That collapses the intrascleral tunnel because it's an angle tunnel. If you just apply pressure, that's good enough.
I actually wanted to ask one question. I've been just reviewing the literature. There is a lot of talk about the toxicity of the BBG dye being caused to the RPE, especially the exposed RPE at the base of the macular hole. And people have been recommending that you put either a thin film of autologous blood or something which keeps the RPE protected. Though most of us I know are doing the conventional BBG staining. So how relevant is that? I mean, do we really need to be protecting that RP from the BBG toxicity?
I think if your surgery is short, there are no issues. If you are anticipating, then it's not a bad idea. But if you look at reports, they are only anecdotal reports of BBG toxicity. Most of the scientific reports of larger series show no toxicity of BBG. There are 3 cases reports, one from Dr. Avinash Pangte's group and a couple of other reports. There is no most of the reports say BBG is not toxic and has been found to be safe.
So would that happen, sir, more if we were doing the staining under air rather than saline?
You don't need to, I think. BBG is heavy enough. It just falls on the surface.
I think for the beginners, sir, because you get a more uniform staining if you've done it under air rather than saline. And I think that's why the beginners, they tend to, do it under air. They prefer doing that unless, they've become confident with it. So I think at that time, is there an added risk if you're doing it under air?
Definitely it will track.
I don't think one should do it under air. There would definitely be a higher toxicity. So by and large, I think it should be under fluid only. And if you're doing it under air, then how do we know how much protective something like blood is? Or you could use something like hyaluronic acid or something like that.
Actually, chondroitin sulfate and viscoat. Viscoat is recommended more because it stays better. Plain sodium hyaluronate tends to shift very fast.
And I think the duration will also matter. Like Dr. Shobhit exposed it only for 20 seconds, So, I mean, if you keep it for 2 minutes, or if you are, while taking out, you waste another minute just while aspirating the dye, and the amount of the time your light source falls into it, and the type of the light source you are using, and the intensity of the light source. All those will add on to the toxicity. And Manisha, I personally feel the youngsters would be able to see ILM even without any stain. I used to peel it without staining it, when I was young. So patchy is good enough. Why you want the whole thing to be stained in the first place?
Yeah, and I think it's initially just when you are raising the flap is the time when you really need to be sure what you're holding.
After that, it just keeps coming on its own.
Otherwise, it just keeps coming. And I
When
think
you have a rhegmatogenous retinal detachment and you put in PFCL for an ILM peel, many times you don't need to stain it. Actually, you can first put in the PFCL, then put a drop of stain if you need underneath the PFCL with the PFCL in place, and that stains beautifully. But if you're seeing folds, you can just pick up the folds and peel off the ILM without even staining.
I think that's very useful, sir, especially when you're dealing with retinal detachments with the macular hole. I think that works very well. Where you have the PFCL and then you are trying to peel the ILM, you get a very good counter traction because of that.
I don't know about the other people in the panel, but I'm doing a lot of peeling even in non-macular hole retinal detachments, where the detachment is not absolutely fresh, and I reduce my ERM risks. I feel it's a good idea to do a non-traumatic simple ILM peel in rhegmatogenous RD also of reasonable duration, not in a fresh case of 5 days old, there with or where even the macula may be on, you don't need to do it. But with a little bit of surface wrinkling or any feature, even in the periphery, I would definitely like to do ILM peel in all rhegmatogenous arteries.
We've been referring a lot to Dr. Eckhart's paper, sir. Shobhit, sir, even you mentioned it. And I remember that in that particular paper, he had given a lot of relevance to aspirating the subretinal fluid from the macular hole using...
Yes, from the margin of the hole, not from top of the hole.
From the hole with the 27 gauge, sir.
Yeah.
So, I mean, does anybody practice even in today's time of draining the fluid with the 27 gauge?
I think, Manisha, you were also there when he showed that video in front. Dr. Cyrus was also there. We all came and started practicing it. But at that time, there were no flaps. So I don't think it is relevant now.
Now you don't need that.
Yes.
You used to feel good, like you go to the edge and the hole will become smaller and you will feel it's closed. But now you don't need it. Now you have the flaps.
I'm personally asking this. There's a lot of talk of this temporal flap. I mean, but I feel very uncomfortable that, I have not really released the entire tangential traction. So do you really find the temporal flap technique useful in a particular situations? Or is that something we have to learn over the time and give up this entire 360-degree peel?
Manisha, there has been a thesis done in our department by Dr. Ramandeep, and I think they have sent it for publication. Sparing the papillomacular bundle versus not sparing. And I thought they found both were effective, but probably ER changes were less if you spare. But I think they will be publishing it shortly.
I think he already has one publication, ma'am, related to macular hole on PubMed. Dr. Rahul.
Already appeared pre-publication or something. I remember bheja tha, but I don't know whether it's come already.
Oh, we also prefer to do the multiple flap technique almost exactly like Shobhit showed in his nice surgery. But I think knowing about the temporal flap is also useful, because if for some reason, suppose you have lost the nasal ILM, and so you shouldn't panic, you would still be quite comfortable and you can roll over the temporal flap and leave it at that. So I think our use of that has been limited to an occasional situation like that.
So that becomes like a hinge flap, sir, basically.
Correct, yeah.
So, Dr. Shobhit, would you ever do this surgery with non-valved cannulas?
No, I have the only use of non-valve cannula in the surgery is for when I have to negotiate my soft tip in. So I just feed a non-valve cannula on top. That's the only use. Yeah.
I was wondering, Trehan still hasn't mentioned chandelier and valved cannula.
Not for this one.
I think in a non-big eye chandelier is a waste. You don't need it. It's only in a high myopic eyes.
Where you're going to do something extra in the periphery that you need to do. Otherwise,
and also for when you're doing a demo, it gives a more uniform.
Yes, the illumination is much better. The recording is much better when you put chandelier.
And frankly speaking, the chandeliers which we are getting here nowadays are not too great. The chandelier. What I miss are the dark twin lights.
Twin lights.
Yeah, those are
Those
The
are very,
dot torpedoes were the best lighting
those were
source.
the twin torpedoes. They were very good.
It was like a threshold now, like it would go.
Yeah, and it was just a 27 gauge entry. You could make
27
it
gauge.
with a needle. You could make it with a needle and go in, and you could
Yeah.
really manipulate those. You
That
could
was
They
really-
are coming with a Constellation adapter now, but I don't know why we are not getting them in India.
I think we had a Constellation adapter for it. The three-pronged, it has a
Yeah.
dot, it has an adapter for it.
I
Yes.
use only Ingenuity. The need for light is very less actually with Ingenuity, so it kind of compensates.
Right.
So any
And
final comments from each one of you for which would be of great help to all those who are plunging into macular hole surgeries?
I think Shobhit made it seem like very simple, very elegant, so everybody should be able to do for all those who are wanting to start doing it.
I think it has become the FACO for the vitreoretinal surgeon today, macular hole surgery.
You
And
made-
somehow, I don't know why, when we were early in our career, we never used to see so many cases. Maybe patients are now coming for surgery. It's becoming very common, macular hole surgery. It's like every OT routine.
Yeah, post-COVID now we are seeing such complex cases that macular hole seems like a treat, you know, it's like having an ice cream. What fun, macular hole. So,
But I think, ma'am, a few things I'm sure all of you would agree that if somebody's starting, start with a pseudo-phakic patient, don't, plunge into a phakic macular hole surgery. And I think this is an important thing. Cyrus knows the bad experience I had, that I had a long eye, a high myopic patient. And on the table, I realized that my instruments were not even reaching the macula. So I think it's a good idea if we can have an axial length measurement before, we are planning a surgery for our patients. Sometimes you can have a surprise right on the table. So I think that's another thing we need to remember. And as was beautifully mentioned by all the panelists, that, start your peeling from the inferior arcade, just in case if you land up with a problem like a retinal break, it's not going to really be, appreciated like a scotoma so much by the patient, because it's going to be in the upper field of view. And another thing is that please be watchful of your duration of the BBG dye being in the eye, because it does have a potential risk of toxicity. So try to just get the limited, or just when you can feel or appreciate the ILM. So restrict yourself to 20 to 30 seconds. I think there's no hesitation initially that if you want to do the staining under air, to get a more uniform staining, please do it, because initially you want to appreciate the ILM very properly.
Yes.
And maybe gradually then you can shift to doing the staining under saline. And
one more thing I'd just like to point out is also don't hesitate, especially since we talked a lot about the combined the membrane along with the ILM, the LHEP, is don't hesitate sometimes to even restain after you've done a partial this thing. Sometimes when you restain, then the edge of the ILM becomes very well defined. So don't hesitate to do a short restaining also.
two small points, Manisha, I would like to add. Even if you cause a small break while pinching this, don't worry too much. Don't try to put a heavy laser there, because it's just like a macular hole, and sometimes the beginners tend to do laser around it. That creates problem. And secondly, while peeling the ILM in the beginning, if you see little bit hemorrhages and all, that's part of the game. So don't panic,
So I also had a few points. One is, I would rather see the ILM properly than worry about BBG toxicity in the perspective of things. So I won't like somebody starting surgery to decrease his ILM staining just because of the fear of BBG exposure. No, you can create more problems if your ILM is not stained rather than with a BBG exposure. That's just to put it in perspective. The second thing is, if you do have that little break, usually these are not full thickness breaks. And if you do, then don't try to peel the ILM from that area or neighboring. The technique, the tendency is to go back to that area and start peeling from there. No, leave that area alone. Start from a different area and cover it in the rest of your ILM peel when you come around. So these two things, I think, and don't hesitate to stain. The area of the LHEMM usually is the area where the stain is not there. And usually when you come to that area, you may lose the edge. And because it's a little reflective and the stain is not that great, restain, you'll find the edge. So I would rather stain rather than worry about the BBG exposure.
And in the eyes where you are inducing PVD using the active suction method and going to the periphery, please examine periphery very
Watch the periphery. Watch the periphery. You'll be surprised how many times there's a break.
You will have breaks there.
Breaks can form while you're doing it.
While you're doing the PVD.
Yes.
I think especially for myopics, you may need to actually be very sure that you've induced the PVD completely. So sometimes you have to keep re-injecting the IVTA and be sure that you have got the proper PVD in place before you go ahead and do the BBG staining. So I think we've had a wonderful discussion on a primary macular hole. We may move on straight to session 3 right now because I think Dr. Hany, it's too early for him and he may take a little more time to join us. And I think Dr. Shobhit, you were an expert surgeon and you were too fast for our schedule today.
Exactly.
So we are trying to wake up Dr. Hany to join in the session. So I think we'll move on to session 3 first and then probably come back to session 2. So please bear with us.
Thank you, Manisha.
Thank you.
Thanks, Manisha. Thanks, everyone. Thanks, Shobhit.
Thank you very much.
Surgery.
Surgery, sir. Need to watch.
Thank you everyone for this wonderful discussion. I'm sure all of us have gathered a lot of useful tips.
Absolutely. Sunday morning well spent.
Yes.
Thank you.
So moving on to session 3 straight away. I would be now requesting Dr. Shalini, who would be conducting the session 3 for the day, which is again a live surgery session. Over to you, Shalini.
Thank you, Dr. Manisha. And now, after the great session 1, we are moving on to session 3. It will be a live surgery on a persistent macular hole. And for the senior surgeon for this case will be Dr. Sangeet Mittal, who has been introduced earlier. So, sir is a prolific surgeon from Jalandhar, and his surgical skills, innovation, and excellent videos we all are aware of. The panelists for the day for this session 3 would be Dr. Pramod Bhende, who is the director of Shri Bhagwan Mahavir Vittu Retina Services at Shankar Netralaya, Chennai. He is a member of the National Task Force for ROP. He is actively involved in teaching and training VR fellows, including me at Shankar Netralaya. He has over 370 presentations in various national and international conferences. The second panelist would be Dr. V.R. Saravanan. He is a senior VR consultant at Arvind Eye Hospital, Coimbatore. He is known for his innovative surgical ideas. He is a part of the VRD training program by Alcon. He has many publications in national and international peer-reviewed journals and has authored many chapters in various textbooks we all have read. Dr. Hany Hamza may also join us in this session. As soon as he joins, we would be happy to have him. He's the professor of eye surgery at Faculty of Medicine from Egypt. And he has special interest in ROP and ocular trauma. He's also on the board of Afro-Asian Council for Ophthalmology. His practice focuses on all aspects of surgical retina, but also includes treatment of intraocular tumors using ruthenium radioactive plaques. Dr. Shobhit Chawla, sir, we have just met and saw the wonderful surgery that he did. So now I would request Dr. Rushil to introduce us to the case number 2, which we are going to operate now.
So good morning all. The present case is of a 52-year-old female patient who presented to our department with complaints of diminution of vision in the left eye since 3 months. So she had a history of macular hole surgery, which was done elsewhere 2 months back. On examination, she had a dense cataract in the left eye and a well-attached retina on B-scan ultrasound. So phacoemulsification with a foldable IOL surgery was performed 2 weeks back. On post-operative examination, the OCT showed the presence of a persistent full-thickness macular hole. So on examination, the right eye had a best corrected visual acuity of 6/24 with a near vision of N18. IOP and anterior segment were within normal limits. She was phakic in that eye with an immature senile cataract, while the posterior segment was within normal limits. So in the left eye, which was the affected eye, the best corrected visual acuity was 5/60 and the near vision was less than N36. IOP was 14 millimeters of mercury. Anterior segment was within normal limits. She had a posterior chamber intraocular lens. So on examination, on the fundus examination, there was a presence of a clear media, disc and vessels were normal. We can see clearly a large full thickness macular hole. On autofluorescence, what we see at the fovea, we can see a hyper autofluorescent area surrounded by a ring of hypoautofluorescence. So this was the OCT which was performed. In the OCT, the basal diameter was 1373 microns with a minimum linear diameter, minimal hole diameter of 691 microns. The macular hole index of this particular patient was 0.52. So with this, we move to the OT with Dr. Sangeet Mittal, who is performing the surgery. So over to you, sir.
So, a very good morning from the Retina OT of Shroff Charity Eye Hospital. So, our surgeon for the day is Dr. Sangeet Mittal. So, we would all like to know the plan for the surgery from you.
Okay. Hello, everyone. So, this is a patient of a persistent macular hole. He had undergone macular hole surgery about a month ago. And unfortunately, the hole did not close in the first surgery. So in this, we are planning to do an amniotic membrane graft, which we are doing epimacular placement of the amniotic membrane graft in this case.
Thank you, sir. So let's proceed for the surgery. Our assistants for the day are Dr. Shalin Shah, our VR fellow, Mr. Kuldeep Singh, our assistant, and our anesthetist for the day is Mr. Ram Singh.
First of all, I'm just going to show how to harvest the amniotic membrane graft. So here we have took, this is the amniotic membrane. And so we are going to, this hole is around 1200 microns on the top. So we are going to use almost 2 by 2 mm of amniotic membrane graft. So we have a caliper. So there are also punches or trefines available to cut this graft for 2 mm size, but here we are using a caliper. So we'll just measure roughly 2 mm on both sides and then we'll get the graft. So I'll prepare 2 grafts beforehand because if something happens to the first graft, we are ready for the second graft during the surgery. Can I have a scissor? थोड़ा क्लीन कर देंगे इसको.
So what company does this AMG belong to? Is it preserved? Which company does it? Name of the company?
This is my first graft that I've taken. So I'll just dip it in saline and clean it. I'll harvest one more in case of any emergency if we need another one caliper. Again, measure something like 2 mm by 2 mm. Nearly, we take this graft. Now, 4-port vitrectomy. Because while dragging the flap or while unfolding the flap, we may need both the hands to unfold it properly. So this is the sclerotomy for infusion. This is a vitrectomized eye, so you have to be very quick. Although this is a valve cannula, so it doesn't matter. On. You have some tape, sticking tape. Good. Goodbye.
So is there an advantage of punch by a punch from
For dermatologists, use a 2 mm by 2 mm punch punch for getting the biopsies for punch biopsy. You can use them. Actually, it's not available easily with ophthalmologists, so I was not showing that. इसमें मुझको चाहिए without valve, no? Sclerotomy or your right hand top sclerotomy is going to be without valves. So because once you insert your graft with the valved cannula, it sometimes gets stuck in the valved cannula, and then it's a difficult proposition to get it out from there. So here we use a one without valves here, right? And one last sclerotomy for the chandelier. One more chandelier. We have this plug here.
So there's a question that do we first explore if an adequate ILM peel has been done in the first surgery?
Yes, we'll do that. We'll inject brilliant blue first, just to see if any traces of ILM are present or not.
And do we stain one side of the graft for orientation?
It's actually we do, but it's not exactly needed, because when you're operating, you won't be able to make out which is the amnion side or which is the chorion side just by looking at it. So it's not actually needed. You need a tactile response for that. You see that chorion side is a bit stickier side, and the amnion is not that sticky. So when you introduce your instrument, as the chorionic side is up, it immediately gets stuck to your instrument.
Does the staining help, sir, one side of it?
I've used the stain, but that doesn't really help. The brilliant blue itself, once we are when we have harvested the graft, we can just stain it with brilliant blue. If you want to do it, I can show it to you. These are the two harvested grafts, and we have just put a drop of brilliant blue over this. But when you're operating, actually, it does not make a difference. You won't be able to make out visually which side is which.
So do you feel, is it better to use a 23 gauge for easier insertion?
It depends on your comfort with the insertion may be easier, but then closure is difficult. Cutter then. With technique कर दो. Right. Quite a large macular hole in there. I think you're getting the view properly or not?
Yes.
So we'll just use the brilliant blue dye to stain this. ठीक है मेरे focus था. That's okay. Brilliant blue. Yeah. So a little bit of dye just to see whether there is any ILM or not here. Backflash. That's good. It's residual vitreous which is there. Okay. There are no traces of ILM here in the center, although it is present in the periphery a little bit, but nothing in the center. Do a fluid air exchange now. Automated speaker. 30 millimeters. For another 5 minutes for the residual fluid to trickle on the macular area, because we need a very dry surface in this case. So, and then we'll do a little more of air exchange.
So does the orientation of the graft matter in closure of the hole?
For earlier, people used to do it as a subretinal graft. In that cases, they used to say that chorion side down towards the RPE is helpful in gliosis. But with the epimacular placement, actually it does not affect much, but still a chorion side down is better because it sticks better to the hole and the chances of dislodgement are less. I prefer to do the grafting under silicone oil. Although you can do it under air also, but I prefer to do it under silicone oil, one, because the visualization is proper. And secondly, because very fine maneuvers are better, you do in a better controlled manner when you are doing it under silicone oil. And third advantage, rarely advantage, some people say that this graft causes a little bit of scotoma. So once the hole is closed and you have removed the silicone oil, during the silicone oil remover, you can remove the epimacular graft also. So it's possible for that.
So in your experience, have you used it in only in the failed macular holes or even in the primary surgeries?
In my experience, I have used only in persistent macular holes and not in any primary surgeries, but people have tried to use it in traumatic macular holes, which are large size and which have stellate edges. And they have found it better results using this graft.
So any other morphological feature of macular hole which tells you that amniotic membrane graft would be beneficial?
Not actually. I have been using it for persistent macular holes. I have not used it for otherwise for primary macular hole surgery. So I don't know. I have not. I can't really comment on that. But for persistent macular hole, it works very well. I've properly done almost. I've done around 13, 14 cases, and only one eye I had a dislodged graft. The other eyes closed nicely.
And how many days, which day OCT tells you that the hole is getting closer?
Even if you do the OCT one day post-op, you will find that there is a hole in the sense the layers may not be yet united, but the whole size decreased and the edges have flattened against the RPE. So by 3 to 4 weeks already taken place, and the depends on the duration of the persistent macular hole. If it is a longer duration, it tends not to close properly. If it is a shorter duration, and this case is very good for that, it tends to close very nicely.
This, like, if you have the options available, so would you prefer this technique over a free ILM flap?
ILM flap again can be done in the similar fashion, but what people have studied, they have done immunohistochemical studies, and they have found that the protein expression is more with the amniotic membrane. And so chances of inducing gliosis is more with the amniotic membrane rather than with the free ILM flap or with the lens capsule they have used in some cases. So I will still prefer. And secondly, in a patient who had already undergone a macular hole surgery, harvesting and a free ILM flap is also very difficult.
And that too from the posterior pole.
Placing a drop of serum or visco over the macular hole and then placing.
Helps in closure, although I have not used it, but it helps in preventing the dislodgement of the graft after surgery, post-operatively. Now I'm going to remove all the remaining fluid. You see the fluid trickle down over the macula, and so I now remove this fluid also. Now we go ahead with this silicone oil injection.
That's a very good tip, sir, because a significant amount of fluid we could notice after waiting for some time.
Even for a primary macular hole surgery, I generally wait 5 to 6 minutes after doing a fluid air exchange to get the macula absolutely dry.
Now we are injecting silicone oil.
And okay, this one. So you see, this is the harvest. The graft now. It's okay. So you see, we'll just harvest this. Just trim it also. थोड़ा सा scissor देंगे. This is a very big graft for that. We'll trim it a little more. A quick scraper dinner to tenors. Once you hold the graft, on one side I'm having a chandelier on and दूसरी needle दूसरी दे दे and grip. This is 25 kg now. Now we have already inside. Scraper. Invert कर दूं. Okay. पीछे से light थोड़ी सी ज़्यादा है. We'll just drop this chorion, it sticks to the forceps. So you just have to induce this. You just need to drop it over near the hole on the macula. Now give me the light also. The light. Now we have to unfold, and this is actually the most trickiest part of this surgery. Just by you have a green lens, sir?
Yes, sir.
Actually, there were two pieces of this graft which got. So now we are just going to unfold it.
Just mention sure it is that unfolding is the trickiest part.
Very carefully, you just have to scrape at the edges of the graft with your scraper. And then slowly and slowly it will unfold.
The visibility is not that good actually because of the silicone oil in place. But I think we can see the process of unfolding.
It's still better if you do it under air, it is very difficult. Even if we are not able to unfold, then nothing to worry, because you just have to go above and place the whole thing over it. It's better if you are able to unfold it properly, but still you have to get it at least bigger than the macular wall size.
There's a question about the infusion. Yes, the infusion is off right now.
Silicone oil now.
It's under oil that sir is doing it. So there's a question that how to prevent a small film of oil beneath the graft.
It doesn't happen actually. There's still some fluid left below the oil, and between the retina and the oil, there's still some fluid which trickles down. There's still a pocket there. So there's nothing to worry about that. Oil, is floats on water, so it will remain up. It will not touch the retina as such. To the macular one. I'm trying if it gets a little more unfolded.
We are using a Tano scraper to unfold the flap. So is there an advantage of silicone oil over PFCL?
PFCL, you won't be able to place the graft below the PFCL. What you can do is, like, if you're doing it under air, you put the graft first on the retinal surface and then you inject PFCL over the graft. But then again, it won't. Sometimes it's very difficult to do it under PFCL. विजिल ऑन डाल देंगे आप कॉर्निया पे थोड़ा सा.
So there's a suggestion from Cyrus sir and Dr. Hany Hamza that an old Tano without a diamond dust works much better to this. What is your opinion?
I've not tried actually. It may be, and I'll keep this in mind next time. But these are re-sterilized. Actually, I've not thought of this and tried invert current.
The amniotic membrane, there's one question about the amniotic membrane. So the amniotic membrane is a preserved amniotic membrane. We preserve, it's an in-house preservation that we do. It's preserved in the DMEM medium, which is Delbaco modified Eagles medium. And we freeze it to -80 degrees centigrade.
Put a little bit oil because the eye is getting hypertenous. Tooth. Oil injection.
There was hypotony, so we are injecting more oil.
Sangeet, would you like to try the same contact lens, or you prefer this?
Almost done. We have covered the hole now. Just more central placement. Once we are over the hole, then we just dip this graft inside the hole. Its graft stands out. This will help prevent us from the dislodgement of the graft again.
So we tuck it 360 degree.
Yeah, almost. We just dip it from the center. It just comes all around. Once it is done, now the surgery part is almost over. We just need to close the case. I'll just wait for another 3-4 minutes just to see whether the graft moves from its place. We'll just hand gripping thing. We'll just see if just move the eye a little bit. And there's a small tissue which was torn. We'll remove that. Clean कर दीजिए. एक बार दोबारा दे दीजिए मेरे को. Just check what is there. Sorry. Even inject some viscoelastic over this graft or whatever, some serum, as somebody was asking. We can inject that, and just to be safer side, but actually it is not needed. I've seen the graft. If you just dip the graft in, it is sufficient to keep the graft in place.
Does the visco which has been placed hamper the closure of the macular hole?
On the top of it, I don't know. Actually, I have not practiced it, but people have used it and they've got good results with that also. Yeah, not yet. I'm not used to this manual inversion. That is. See, the graft is still in place.
Any specific post-op positionings you recommend for this case?
Initially, the patient will lie supine for a few hours, right? And then he can take up any side of whatsoever.
The usual prone that we.
Not prone. No. Shake the eye a little bit just to check whether the graft is moving or not. I think it's quite stable now. Removing, take care, you remove the unvalved cannula first. Okay. You can even use the backside, as you were discussing earlier. You can even use the backside of your forceps to smoothen the sclerotomy. Pardon? Anything? Ideally, now we should allow the patient to lie straight now for 2-3 hours. Irrigation.
So what are the chances of graft displacement in post-op and any specific reasons that you have seen?
13 to 14 cases on one case I have found.
And any specific reason you noted?
Maybe it's a learning curve initially.
It was an excellent surgery, sir. Yeah. Thank you very much. Yeah. Now we'll move to the discussion in another 2 minutes.
Hello, Pramod.
Hello, sir. How are you? Good morning. Good morning, Saravanan.
Morning, sir.
Good morning, Saravanan.
Morning, sir.
If you had been here, Saravanan, you and I could have done a beautiful shoot together. Yesterday I did at Lotus Temple. It was a delight.
Great, sir. Great.
Saravanan is also expected.
Yes, please stop the screen share, Mr. Singh.
Pramod, sir, can I ask you a question, sir?
Yes, please.
How do you plan on going about choosing which surgery to do for your cases when you have a recurrent non-closed or reopened hole? You have the options of hinged flap, free flap. You have the autologous retinal graft, and you have the lens capsule as well as the which Dr. Sangeet sir did right now. So how do you go about choosing which case you choose for? I mean, which
I do not have experience with autologous retinal graft or even amniotic membrane. I have not used most of the time. What I rather I would to try, if edges are elevated, if you feel some tug or traction is still there, and I would either even try it sometime just a simple injecting the gas, position him and try, and few cases it works. That's the simplest way you can do it. Okay.
Pramod, do you like to add PRP to it, platelet-rich plasma?
No, I have not again had experience with that. I know that used to be done. That was actually initial practice when TGF beta, and then subsequently came at a either autologous serum, or people used to just induce. Steve Chal used to cut the edge of somewhere near macular A, so that induce the bleeding there, and that itself act as a you have a fibrotic factor and which will probably help in a closure of the hole. I don't think we do anymore that much nowadays.
Okay,
Of course, we are revisiting again all these things.
I would like to share my experience on this. We are doing it still. I either put whole blood or I put PRP. Even if I'm doing a free ILM flap for a failed macular hole, I put it as a double surety and it really works. It really works.
Yeah, I don't have experience with that actually. I do not have experience. But what I will do is I'll try to look for an extra ILM somewhere. And if I can bring that back intraoperatively or have a free flap. Again, now, initially, see, concepts are changing. None of us are really sure like what really works 100%. So initially we started living like that. We started stuffing the flap. Now we realize stuffing flap itself is a problem. Then subretinal flap or over the ILM. I think exactly what works, I don't think anyone really knows till today, because you feel the worst possible thing, like I did a case very badly and that the hole closed excellently and you think you have done an excellent job and it doesn't close. What I insist on is first post-op, I mean, immediately after surgery, that's my protocol now, immediately after surgery, have a just prone position, straight goes, patient goes in a ward and immediate prone position. That's what I feel the most effective way of doing, because fluid accumulation, if you don't allow that and you have a capillary, you have a RP pump functioning, macular area is dried, and probably it works best. That's what I feel.
Shobhit sir, how do you prepare your PRP, sir?
I call for a centrifuge. A person comes with the centrifuge from a lab and they take half an hour and they prepare it of drawn blood. And this is done before while I start the surgery when 15 minutes have passed of his preparation. And by the time I'm at that stage, I have the PRP in a syringe, which he gives me. It's done in a syringe. This syringe goes into the centrifuge.
Okay, sir.
Directly, I have just put 2 drops onto the macular hole.
How do you ensure the sterility, sir, of that?
It's a whole sterile vial. Everything is disposable and sterile, including those syringes. Everything is sterile. I've just drawn the blood in that syringe only by a gloved assistant. Even the operator is in scrub, wearing a glove and gown. It's a whole sterile process.
So what is the advantage of?
I've never had any. I've done 6 cases. I've never had any issues.
Okay.
Only 6. My experience also very limited. Whole blood, obviously there was no issue at all.
Dr. Meena Chakravarti from Trivandrum, she uses the dextrose blood. She mixes equal volume of blood with 5% dextrose and then injects it over the
yeah. You can do whole blood also, or what Dr. pointed out, that you induce bleeding and just, shovel the blood onto the macular hole. But I think the more elegant way is to have it in a syringe and put 1 or 2 drops.
And I think there's a published report of Steve Charles where he has done a small arcuate retinectomy just temple to the edge of the macular hole.
Yes.
A very large holes. I think he has done that also.
As a relaxation.
Relaxing temple arcuate retinotomy.
But I feel I've done traumatic holes about 2000 micron in size. I've seen they close by secondary intention. There is visual improvement also with free ILM flap or ILM flaps, which are also next to the hole and hinged. Somehow ILM flap really works well. It's only for secondary surgeries that we have to resort to.
I wanted to ask actually Dr. Sangeet that would this amniotic membrane graft be like a second procedure after you have the primary failed, or would that be an option even after you have tried like a free ILM flap or some other way of dealing it with?
You can, if you feel that free ILM flap is available, when you stain the brilliant, that's the reason why we stain it with brilliant blue before we proceed with the amniotic membrane graft, just to see if enough ILM is available which you can harvest and use it as a free ILM flap. But most of the times, if you have done a primary surgery with good ILM peeling, it is not possible to harvest ILM in those cases.
Can I ask a question?
Yes, sir.
Sangeet, in your setup also you normally use fresh amniotic membrane like this one, or you use the preserved one?
So generally we use the fresh only, like not, this is also preserved ones only, which we get.
No, one comes also freeze dried, which you have.
One comes freeze dried. I generally use the wet one which comes into a liquid.
Is the freeze dried, if you're using the freeze dried, you have to hydrate it first with.
You have to hydrate. So anyhow, you have to wash this also, and you have to wash that also before inserting it inside the eye.
But that's in a sterile pack. So
sterile pack.
The washing is done to hydrate and make it more maneuverable.
Yes. You have to. Otherwise, once you see, it's the most difficult part is unfolding the amniotic membrane on the retina. So the dry one, they generally fold very quickly. The wet ones, they generally, again, unfolding is easier as compared to the dried ones.
Most of the review articles also say that the amniotic membrane, you're just providing a basement membrane, collagen, and that's it.
It's just providing a scaffold.
Yeah,
and it allows the glial tissue to grow underneath and the macular hole closes.
What's the difference between putting it inside below the retina and just as you did in the MRI?
People have done with the in fact, earlier it was done with the subretinal grafting as a subretinal graft only. So, but then the procedure becomes more traumatic, especially in the cases where the retina is attached. Then you have to cause a detachment and then you insert the graft below the retina. So you generally, sometimes you traumatize the edges of the hole while doing that. So it's less traumatic.
When do you plan to remove this, sir?
You can remove it when you remove the silicone oil. You can remove it side by side also. So you just with your tenoscopy, you just lift the membrane, it just comes off.
What happens if you don't remove it? Like patient does not come for a follow-up. Is there any adverse effects?
No, there is no resultant scotomas from this membrane. People have done microperimetry studies and they have found there are no scotomas due to this membrane. And otherwise, also it does not integrate with the retina as such. It just remains over.
One more thing I was that doing the procedure under oil, we have this like cloudy dispersion during the oil injection.
This is the first time I've got this. Just below the lens, there was some kind of opacities.
This happens because of the low-grade oils, sir. So I was wondering whether
I think if you use a better centistoke oil, if you use a 1500 or 2000 centistoke oil, it will be a better option.
I think it's a known thing actually. All of us must have learned when you feel the eye and you see that the cloudy film comes up, floats over it. That's it's not like uncommon when dealing with the silicone oil. Probably it get washed up next day, you don't see, but intraoperatively that sometimes can cause a problem. But I was also feeling like Mahesh answer whether infusion, I wanted to know whether infusion is on. What I mean, because we know if you are working under silicone oil, probably having a silicone oil connected infusion, and because intermittent hypotonia again cause problem while working under these in these eyes. So you have a silicone oil connected and intermittently keep on talking about maintaining the normal intraocular pressure, and that's like a globe integrity. I think again would have helped to maintain that visibility.
I agree with
easy to handle relatively. I mean,
so I agree, sir, that if you have a silicone oil continuous infusion, that will be better. But in those cases, sometimes you overfill the eye and then also post-operatively.
No. What I mean is not continuously overfilling, but you keep on topping up, not continuous overfilling. Because whatever said and done, we call these are so-called wall cannulas. We all know they leak. They keep on leaking, and particularly you have one sclerotomy without wall, and you are manipulating through that. Oil keeps on leaking from the sides.
Yeah,
so it will be there.
What is the distance? Like, I thought it would have been easier to do under PFCL with at least half the cavity filled with PFCL. What is the difficulty? Have you done?
PFCL again? Once what happens is like when you put the graft over the retina, and then you have to put the PFCL over the graft, because once you have put the PFCL and then you
you fill it a half fill with the PFCL, and do the whole thing under PFC? Like what you did under oil, the whole process you do under PFC.
I once tried using with the PFCL also, but that was the main problem that occurred. It was that you can't take the graft below the PFCL then, once you have put the PFCL over the retina.
Probably, again, just to modify Saravanan's question, just subtle film of PFCL, not even half feel, like a half cc or quarter cc covering on, like what we do for ILM peel when detached retina sometime. If you use that one, because the silicone oil, things become sticky. Because see, this is I'm thinking again, hypothetical situation. I personally have not put amniotic membrane, so I have no right to discuss and criticize. Just looking at to make things easier, probably we can just again try under PFCL once with a very, very thin film of PFCL, which may, because unfolding become easier in air than, fluid than in a silicone filled eye sometimes.
I think Trehan has a nice question in the chat box, because all the free flaps, hinge flaps we do under PFCL. That's why how is it different? He's asked a question. Like I think the same question I was trying to ask to Sangeet sir.
No, but I tried it once. Before I tried it with oil, I tried with PFCL once, and that was the only thing that came into being. Once you have put the bubble of the PFCL over the retina, then it's very difficult to get the graft under the PFCL. So either you have to put the graft over the retina, hold it with the end gripping forceps, and with the other hand you put PFCL over it, then it might stay over there. But then I found that with silicone oil, it is easier as compared to air. PFCL I tried only in one case, and I told you what happened in that case.
Saravanan, I wanted to ask you, have you used the preserved amniotic graft as compared to this fresh? Because I found that is very difficult to unfold and it's quite rigid. I wanted to know if you have used it and what is your view and Sangeet's view.
I personally have not used AMG. I used lens capsule, I used autologous graft, but I have not worked with the AMG. Sangeet sir can answer that question. Okay, he wants a comparison between the preserved as well as the fresh.
Yeah.
So I have used both, and again, what you have felt is like the dry graft. It's very difficult to unfold as such. Even the wet graft is very difficult to unfold, and dry becomes even more difficult.
That's why I came back to autologous ILM graft with PRP combination. I found that much easier to do in my hands because I have not tried fresh yet.
Sangeet, another theoretical question maybe for you because you have experience. Why not to just do straight under fluid? Because things maneuvering become much easier, and as you suggested, that one surface, that chorionic surface is generally sticky.
It's not.
And if it is sticky, we take that surface on the retina, and once it sticks, probably under fluid, do you think it will be easier to handle? I mean, again, I'm just asking because you are experienced.
That sticky side keeps on flying actually. When you try to do it under fluid, the graft keeps on flying here and there. Once you leave it, and then when you're going to do the air fluid exchange, it again slips off and comes into your fluid needle. So it's not very easy to do it under fluid itself.
No, because one surface is sticky. That's the reason I'm talking about other surface floats. I agree with that.
Yeah, but this is not as sticky. It's not like glue that it will keep on there. So you have to hold it with something. Either the other option, as Dr. Saravanan has suggested, is PFCL. But then you have to hold the graft with the end dripping and put it on the surface of the retina, and then put PFCL over that. Because once I did it, it was almost impossible to take the graft under the PFCL bubble.
MP sir, you do it under fluid. What are your tips of doing it under fluid?
Under fluid?
MP sir usually does it under fluid.
Yeah, like I switch out the fluid, then like what happens is the currents are not there. So once it is inside, use the blunt tip of the cutter to push it inside and just keep it at the type. Like it has to be a little bit pushed into the hole. So that's something which has to be done. It cannot be placed on the surface. If it has to be placed on the surface, then you have to drag it under the PFCL bubble. So what we do is like to take it to the edge of the bubble, then drag it under the PFCL bubble. That's something which can be done. Or like Dr. Sangeet mentioned, take it inside with the forceps, then put PFCL overlying the graft and do it. But it's not that difficult if you switch out the fluid, and particularly I use gravity aided infusion. So it's not the constellation where it's a machine aided infusion. So I switch out the fluid, then push it inside, tuck one edge into the hole, and then it stays there. That's not a major issue. And a very careful FG and put a bubble of visco on the top of the amniotic that keeps it in place. So I don't use silicone oil. Very nicely done, Sangeet. Congrats, great surgery. But like a silicone oil, like to me, I think it gives rise to a little bit of too much of interfaces. So you have fluid, silicone oil, then again another layer of fluid. So in PFCL is also possible, but once again, because of its convex surface, it sometimes gives rise to a problem. But I do most often with fluid. I agree, it's not easy, but then like once it is pushed inside at the hole, then it stays there.
Dr. Mahesh, are there any specific precautions when you're trying to cover an optic pit with amniotic membrane as compared to a macular hole?
I have done very few, Dr. Shobhit, but then like what I would do is again try to see if I can push it inside. Like if you see Dr. Naresh from Arvind, he literally comes it inside. But I try to see if it just be covered or very gentle pushing it inside. What I would do, but then I haven't done too many. I think Dr. Naresh has much more experience than me.
So MPSR, you mentioned that you are tucking in the amniotic membrane. I mean, is it really essential to be doing that step?
What happens is not, it doesn't have to go subretinally, just that you engage one part of it into one edge of the hole. That's good enough to keep it in place. Then subsequently you can do an FGE and then it remains in place and then brings the edges of the retina together. So this here acts as just a template, isn't it? It's just for the retina to overgrow it. And the European group has shown that keeping it underneath actually seems to have a better visual outcome is what they have indicated in the subretinal space. So that's what they have indicated. At the present moment, we really don't know which works, but they tend to think that like keeping it under the retina, under the macular hole seems to have a better visual outcome.
And again, as you mentioned that you're putting a drop of the visco to keep the graft there, isn't that also hampering the closure of the hole because it's coming on the way?
It's on the surface, right? So if it is, as I mentioned, the whole thing is, I don't put it underneath the retina. Like the European group, they put the whole amniotic underneath the retina. And I do use a preserved membrane. Like the discussion was going on, the preserved membrane is a little bit difficult to handle because it's not that pliable, it's not that easy. So if it's a fresh membrane, then it can go under the macular hole. But this is like, this will partly go over, partly under there. I just want it there until I get the air inside. So once I have the air inside, then I can manipulate under the air to keep it on the surface. And on the surface, on the top of it, through the air, I'll put a bubble of viscoelastic to just keep it in place so that when I'm doing the FG over the optic disc, it doesn't accidentally drag the amniotic into that. That's what I would do.
I agree with Mahesh because again, it's like any other free flap. We want it to be in place, so we have to anchor somewhere. It is not a plugging the hole fully, but unless you have that little bit squeeze, press, and then release, and then it holds on there. But if you just keep over that, just stationary, without pressing, probably again when you do fluid erection, and that's why I think your viscoelastic will help to hold it over time being. Sangeet, one more question, sorry, I have here. See, you said just after fever, no positioning. Theoretically, again, no positioning mean why oil inside at all? Because you are not using it for a tamponating effect at all.
So oil, as I earlier mentioned also, oil, one thing is visualization is better, then control of your movements is better as compared to air. I have now experience with fluid as such, but as compared to air, it is better than controlling this graft under the oil.
Agree. Yeah.
And again, when you're going to remove the oil, you can remove the graft also at that time.
do really have to remove the graft at all, or we can leave it
We
behind?
can leave it like that.
In I think that one of the RetNet meetings, somebody had shown that the subretinal AMG was persisting for close to a year under the.
Yeah, Tapas Padi's video was there in one of the RetNet meeting. Tapas says more than a year. Yeah, I agree with you. So LBP Bhuvaneshwar.
So any advantage or disadvantage of leaving it there?
No, we do not have, Manisha, I do not have experience, because while passing comments on this, Sangeet only said that probably some few people have mentioned that about field changes, and particularly macular area, even a little bit larger area get covered, definitely maybe patient may be symptomatic. I do not know. Again, Sangeet.
People have done some microperimetry studies after doing this graft, and they have found that there is no significant difference.
It is not that they wanted to leave it in behind, but I think if I remember it, this was published, this was presented much before Retisurge's group actually. So this was about like 5 to 6 years back. They presented in RetNet.
Yeah.
I don't know if they didn't publish it. So they just showed that it persisted, not that like they wanted it there, but then it just persisted. That's how it was.
Sangeet, how do you decide the size of the amniotic membrane graft that you are taking?
So we when we do a OCT, pre-op OCT, we take the top diameter of the hole.
Okay.
The top diameter, and we have to keep the graft which is at least bigger than the top diameter of the hole. Generally, I keep it double of what the hole size is.
There is a question which has come up that do you experience any uptake of the graft or a blood flow in this graft on Octa? I don't know. I thought we were just using it as a scaffold probably.
Yeah, it's just like a scaffold. It does not integrate with the retina at all.
So any other VR surgery you have used an AMG for?
No, not only in persistent macular holes.
Mudit has used, actually, he has used, I think, no, this is a fibrin glue, I think.
Yeah, that was.
They were trying something again. Or breaks, retinal breaks, peripheral other breaks. Raja is there. Raja can comment maybe on it.
Yeah, Mudit has published for closing the peripheral breaks, like instead of doing a buccal or a vitrectomy silicone oil. So that's what he has done. And it is published like, yes, it works, but not in all patients. You can't really avoid the glue flowing over the surface of the retina or the undersurface of the retina. That's one. I have had one patient where there was a fair amount of inflammation and unexplained vision loss. So this was a tissue glue. This is not cyanoculate. Cyanoculate is particularly bad inside the retina, inside the eye.
Long back in 2008 or 9, there was a publication in Retina Journal. It was called aqueous tamponade for regardis. So the meaning they didn't do any tamponade, either glue or anything, just laser. So what they do is they laser the break under here and then slowly fill the fluid from the disc level rather than from top level, so as not to disturb the freshly attached retina. It does not detach on table, they just leave the aqueous as it is. I mean, the BS is as it is. They call this aqueous tamponade for retinal detachments, and I think they mainly did for fresh surgeries, and they have explained that the fresh laser was strong enough to hold the breaks in place.
Trehan, you just mentioned that you have used it in a perforating injury. Would you explain how?
Yeah, we had a patient. We presented this at RetNet. We had a patient with a perforated, with a foreign body that had gone through and was in the courts of this, was in the sclera, just beyond the sclera. So when we went, we couldn't make out on the CT. Actually, we thought it was within the courts of the eye. When we went in, we found there was a gap, and that gap was leaking air. It was leaking PFCl, whatever we put. So we put a AMG with glue. It worked. It sealed the gap, and this guy got back, I think 618 or something. We presented that on RetNet, I think last time or time before that. Although I must tell you that Dr. Gupta had said at that time during the discussion that even if we had left it like that, it would have closed. But then once we didn't know that the foreign body is actually through the courts. So when we went in, we assumed that the part of the foreign body at least is inside the eye. When we went in, we were faced with this gap. And at that time, we could have left it because then whatever was the intraocular content was actually leaking. So we had to seal it. We tried with a lens capsule flap. We tried with one layer of AMG, it didn't work. Then we layered the AMG and put with glue. We tried only with AMG by stuffing it, it didn't work. Then we just layered it on top and put glue and that worked. We have the video of that also somewhere.
And anybody has an experience of using this for an optic nerve pit? I think Dr. Shobhit also raised this question. I mean, for stuffing it into it.
There are studies published with amniotic membrane graft over the optic pit, but I think optic pit, there are many other options. Like nowadays, only if the eye-lamp flap fails, you will think of doing this as an option, keeping this as an option. Eye-lamp flap will be the first option for an optic disc pit.
So any, I think, final comments from each of the panelists. I'll start with Dr. Sangeet. I think if somebody is starting to do this procedure for the first time, what would be the crucial steps that one needs to keep in mind? I think that's very important.
Yeah, the most difficult, when I started doing this, the most crucial steps are the two steps. One is like dropping the membrane over the macula, because then you have to be very, that's why you need a bimanual surgery here. You have to just, the membrane sticks to the forceps and does not leave the forceps as such. So you just have to keep on pushing with either with another forceps or with the tenoscraper, and then you drop the membrane over the macula. And second is unfolding of the membrane takes a lot of time. Once you have unfolded, then you just drag the membrane over to the macula, then just dip it in the macular hole, like at sieve when you use it as a filter for to put in a glass. It should be like that. The edges should be a little bit raised so that it does not get dislodged later on. As Dr. Mahesh also said, that you have to have some kind of scaffold in there for this membrane.
Saravanan, sir, your tips for the MG?
Personally, if you have a recurrent macular hole, first you have to make a call whether you want to really reoperate. Being a very, like suppose the patient is very old with a normal other eye and she's not very keen, I will not be very pushy in these cases. But once you have decided to operate, we have a lot of options like which based G and regas, like Pramod sir was saying. Right from that, my usual preference is free flap or hinge flap. Then you can go in with other options. Break is very, very large with elevated edges. But in between, you also have the lens capsule graft if the patient is sort of big or you're planning to do a cataract surgery on table. The PC is a little bit more thin and more pliable, but the anterior capsule is quite thick. You can use it almost like but easier to place. Other air also. So all these are options at your hand, but you'll have to make a call depending upon each individual patient. And before deciding to operate, also always make sure that the patient is okay with all this, that she's willing to get a resurgery, because you have to immediately have the first surgery again, positioning and being immobile at home. It's sometimes a very taxing on a very elderly patient. So you have to keep that in mind also.
Thank you, sir. PV, sir.
Yeah, more or less. And basically, I was wanted to tell you, like, patient counseling is extremely important here. And theoretically, for us is nice. OCT shows hole is closed, or microperimetry shows. But whatever we all experience, final visual outcome may not be that great in a patient point of view when you look at it. So, doing a great surgery, but if it's a 360 becoming 460 or 560, generally they won't go like a 618 or 612 or 69, what you get a primary closure surgery. So all these things we have to have a long discussion with the patient and attendant, because the moment you sometimes second surgery, third surgery, their expectations go high. So that we have to keep in mind before taking these cases for surgery.
Totally agree, sir. Shobhit, sir.
Yes, ma'am.
So your
Well, I like to stick to what Dr. Pramod said, keeping those factors in mind, the situation of the other eye, weighing the visual improvement. I like to still stick wherever possible to a free ILM graft combined with PRP for closure of the hole. And if I have to give the patient a chance, and definitely we discuss the pros and cons of the surgery in detail with the patient, then only the surgery should be attempted. But normally the combination of a free ILM graft and PRP definitely works towards some visual improvement, though not dramatic.
Thank you, sir.
That's been my experience.
Dr. Hany, your tips on this persistent macular holes, especially the AMG graft.
Good morning, everyone. First, it's my pleasure to join you in this meeting. And for persistent macular holes, I would go according to the size of this hole. I mean, I can go for smaller holes for a free ILM graft first. If it fails, I would go for an autologous retinal transplant or an amniotic membrane graft. Although I believe both of them acting as a plug, I would rather prefer the amniotic membrane instead of creating a new retinotomy and creating a new hole in the retina, actually. And both of them achieve the same results, actually, visually, because both of them are not integrated in the retina. They act as a plug. And in my presentation, I'm going to show you, I mean, a small variety of cases for these techniques.
Sure, sir. Thank you.
Thank you.
Now let's move to the next session, session 2 initially, which is now the third session. And I will pass on the podium to Dr. Manisha Agarwal. She'll take over there for the next session.
Okay.
Thank you, Shalini. So a very good morning, Dr. Hany. Good to see you finally join in.
Thank you, Manisha. Would you like me to share my screen now?
No, just let me introduce you to everybody.
Okay.
You're well known in India, so I'm sure all of us know you.
Thank you. It's my pleasure.
I welcome Dr. Hany, and he's the professor of eye surgery at Faculty of Medicine, Cairo, Egypt. He has served as the general secretary of the Egyptian Vitreoretina Society and is the current vice president of the society. His practice focuses on all aspects of surgical retina, but also includes treatment of intraocular tumors using ruthenium radioactive plaques. He has special interest in ROP and ocular trauma. He is also on the board of the Afro-Asian Council of Ophthalmology. I think Dr. Hany needs no introduction. He is a constant visitor of India. We get to see him in every VRSI, and we love his talks and his surgical expertise. I will also introduce the panelists for this session. We have Dr. Mahesh Shanmugam. He's the head of Vitreoretina and Ocular Oncology Services at Shankar Eye Hospital, Bangalore. He's the co-founder of RedNet India. He has received various awards, including the Swarnlata Punshi for Best Research Worker, Shankar Netralaya, Chennai, and also the Colonel Rangachari Award presented by AIOS for his best paper. I'm sure he is a great teacher and also my mentor, and most of us, we have learned a lot of vitreoretina from sir. We have Dr. Unnikrishnan Nair. He's the medical director of Chaitanya Eye Hospital and Research Institute, Kerala. He's also a well-known, very well-known figure for organizing the Retina Imaging Congress, known as RIC in his terms, every year. And he is an avid researcher and has multiple publications and has delivered multiple talks, both nationally and internationally. Dr. Sangeet Mittal, who just performed a wonderful surgery of AMG graft, he would also be joining us as a panelist for this session. So over to you, Dr. Hany.
Thank you, Manisha, very much. And again, I would like to thank you, Sangeet, and the organizers of the meeting. And it's always my pleasure to meet my Indian friends and colleagues. As you mentioned, India has been always on my schedule for visits, and I always enjoy your meetings and everything in your country. I love your country. So I'm going to share my screen now. Just a moment. Share screen. Okay. Okay. Can you see my screen now?
Yes, very much.
Okay. Today I'm going to discuss what we do after finding an open macular hole after ILM peeling. Macular holes developing after vitrectomy and ILM peeling can occur actually in two clinical settings. The first one is a persistently open macular hole after we have done a vitrectomy and ILM peeling for a macular hole. That is a failed macular hole surgery. The second one is when you have a case of retinal detachment or PDR and you do ILM peeling during vitrectomy for this case to prevent postoperative macular pucker. And postoperatively, you are confronted with the development of a de novo macular hole, and the ILM already has been removed in the previous surgery. A persistently open macular hole, which is the first clinical setting, can be due to a large size of the hole, retinal scarring around the hole, or simply there is inadequate tissue to bridge this defect. While macular holes developing de novo after vitrectomy and ILM peeling have been attributed to weakening of the retinal glial cells. Simply ILM peeling is a maneuver that causes decapitation of molar cells, and this predisposes to disruption of the retinal surface and the formation of a macular hole. This can occur due to traction from an adjacent epiretinal membrane, and I have one case to show you how this developed postoperatively. Contraction of the residual ILM has been reported in some cases. Direct mechanical trauma to the retina. ILM staining dye toxicity, and this occurs especially more with ICG stain. And one interesting clinical setting is the complete peeling of the ILM for cases of lamellar hole epiretinal proliferation. In these cases, if you do a complete peeling of the ILM and you do not do a foveal sparing ILM peeling, the incidence of postoperative macular hole has been reported in some cases to be up to 30%, a full thickness macular hole. What are the surgical options we have? In small to moderate sized holes less than 500 microns, we can use a free ILM graft, but in larger holes or in cases of failure of the free ILM graft, I resorted to autologous retinal transplant, the technique originally reported by Tamer Mahmoud, and the amniotic membrane graft in one case, as I'm going to show you. Now, let's go to the clinical scenarios of these cases. The first case is a male patient, 42 years old. He had a previous vitrectomy and ILM peel for a macular hole 8 weeks earlier. As you can see, he has a persistently open macular hole on OCT. So you go in again, and I plan to do a free ILM graft. Remember that the most difficult step in this case is to release the ILM from the tip of the forceps. And in many cases, you have to resort to a bimanual technique. You simply remove the ILM and put it inside the floor of the hole. Postoperatively, this OCT shows closure of the hole and partial restoration even of the outer retinal layers. And this patient achieved a best-corrected vision of 0.2 after 3 months of this surgery. Now, this is the second case, and this is a male patient, 58 years old. He presented to me with a left rhegmatogenous chronic retinal detachment. I did him vitrectomy and ILM peeling, and due to the viscid subretinal fluid, it was not expelled by the injection of perfluorocarbon and anterior retinotomy. So at the end of surgery, I was confronted with a large amount of viscid fluid in the posterior pole. For this, I did a drainage retinotomy above the optic disc and drained the remaining subretinal fluid. Postoperatively, although the retina was attached, but you can see that he developed a macular hole having its long axis pointing to the direction of this retinotomy. Traction from this area of the retinotomy induced this postoperative macular hole. You can see this long axis as I have put it. So I went in again and I stained. I couldn't find, of course, I have removed the ILM in the first surgery. And as you can see, these small pieces of the ILM Simply you put them inside and they float again, and you reposit them, and you use an old Tano scraper to fix them in place. And finally, I did a fluid air exchange and gas injection, putting only this small piece of ILM inside the macular hole. Although the hole closed, but in this case, it's an irregular closure with incomplete restoration of the retinal layers, and the best corrected vision was 0.05 with eccentric viewing. Quite a disappointing visual result for me and the patient as well. Now, this was my first case of autologous retinal transplant, and I see you how I went through this case from the beginnings. She's a female patient, and she was referred to me with recurrent macular hole after 3 previous surgeries. The first surgery was a vitrectomy, ILM peel and gas. Second surgery was silicone oil injection for the persistently open hole. And the third surgery after removal of silicone oil, and this is the OCT after the third surgery upon referral. So I went in, although it's a big hole, I decided to go for free ILM graft first. And I do it under perfluorocarbon. I move the pieces under perfluorocarbon. The advantage of putting perfluorocarbon is that it isolates the area, the operative field, from the fluid turbulence above. So you are working in a more or less quite fluid medium. And using the bimanual technique, I started to put the pieces of the ILM inside the macular hole and did a fluid air exchange. And during fluid air exchange, you do remove the fluid only above the optic disc, and you do not touch the macular hole. Otherwise, you're going to dislodge these pieces. So this is the post-ILM graft OCT, and the hole is still open as it was before. Nothing has changed. So I went into the fifth surgery in this patient and decided to do the autologous retinal graft. I marked the area where I'm going to take the graft with laser, and then I inject a small amount of fluid using the 41 gauge needle, started the section of the autologous graft using a bimanual technique and a scissor under perfluorocarbon, and I dragged it successfully and put it inside the macular hole. Since this was my first case, I decided to do a fluid air exchange, and the flap dislodged, as you have seen. So I decided to take another piece of retina from the upper nasal quadrant and repeat this same technique again and put it again inside the macular hole. But this time, again, injecting perfluorocarbon, and this is cutting of the graft freely. And I dragged it using the tip of the forceps, put it using the same orientation on the macular hole, and started to unfold it under perfluorocarbon. This time, before I remove the perfluorocarbon, I have put viscoelastic above it to prevent its dislodging. I did not want to leave silicone oil in this case, as it was its fifth surgery. And this is the post-operative OCT after 8 weeks. The hole has closed using this plug, but vision is 0.05. It's an irregular closure, and as you can see, it ended up with scarring or gliosis within the macular area. Although it's an anatomical success, I would not consider it as a functional success. Now, this is the fourth case, and this is a 14-year-old boy with Stickler syndrome. He's one-eyed. He had a failed vitrectomy in the other eye. And he presented with a left rhegmatogenous retinal detachment with a large inferior break and PVR. I operated on him. I peeled the ILM. He had no macular hole at this time, and I injected him with silicone oil. 6 weeks later, he had an aggressive recurrence of PVR, multiple traction holes, including a large central macular hole. So I went in again, and I removed the silicone oil, injected perfluorocarbon. This is the large macular hole in the center, and you can see the multiple traction holes in the periphery. I did a generous inferior retinotomy, 180 degrees, and then I started to mark the area where I'm going to harvest the autologous retinal graft using the bimanual technique. I had some bleeding, but this stops by elevating the intraocular pressure. And then I started to drag the autologous retinal graft and put it on the surface of the hole, as you can see, to close it. And I did a direct PFC silicone oil exchange in this case. And this is the picture at the end of surgery. Post-operatively, the retina was attached. I removed the oil after 3 months. And this is actually, I did a microperimetry after 3 months, and you can see that there is a central scotoma. The sensitivity is only at the periphery. The flap did not exhibit any integration or any function, but keeping the retina attached in this one-eyed child was a success, although vision did not improve more than 0.15. Now, this is the 5th case, and this is a female patient, 40 years old. She had a right retinal detachment with a macular hole and peripheral breaks. I did vitrectomy and inverted ILM flap, as you can see in this surgery. This is the first surgery in which I did an inverted flap using the envelope technique. So I peeled from all sides, and I just put the ILM inside the macular hole. This is to show you that the ILM has been peeled in the first case. I completed my surgery, did the endo laser, and injected silicone oil at the end of surgery. And 1 month after I removed the silicone oil, she developed a recurrent retinal detachment with a large upper retinal break and a large macular hole and no trace of the ILM, as you can see. So in this case, again, I decided to do the autologous retinal graft. Usually we harvest the graft larger than the size of the macular hole to allow for shrinkage, which usually occurs when you move the graft. Now I'm unfolding it on the top of the hole. And again, we did a direct PFC silicone oil exchange. And the graft usually remains in place when you do it with this technique. The last case is a male patient. He is 57 years old. He had a previous vitrectomy and oil for retinal detachment elsewhere. The retina was attached, but with a large macular hole, and I can see bare sclera at the floor. There is no RPE. His vision was, counting fingers, 60 centimeters. I went inside, and you can see the floor of the hole is white. There is no RPE. I tried to look for any residue of the ILM using staining, but I couldn't find any. So I decided to use an amniotic membrane graft. Harvesting the graft, you can see some bleeding at the floor of the hole from manipulations. And this is the harvesting of the graft. I took a small piece and put it on the tip of the forceps, and simply I used it as a plug, putting it inside the macular hole. I did not care very much for the orientation, and I don't think we can control this very much because of the extreme mobility and being so soft, this flap, it folds upon itself. And I just plugged it inside the macular hole under silicone oil. I did not remove the silicone oil that the patient had originally in this eye. Post-operatively, actually, I was very reluctant to test the patient's vision and even to ask him, except when he reported that he improved. And when I tested his vision, I found it to be 0.1, which was very surprising to me. Unfortunately, this patient came from Yemen and he traveled back, so I didn't have the chance to follow him up longer. To conclude, post-ILM peel macular holes need additional tissue to be added to bridge the defect. For moderate-sized holes, ILM graft can be enough. But for very large holes and after failure of ILM grafts, we need a full-thickness retinal graft or amniotic membrane, which are both valid options. Visual results are variable, despite successful anatomical results. I think the visual results depend more on the amount of viable photoreceptors at the edge of the retina of the patient. It's not dependent on the tissue we are putting inside the macular hole. because currently there is no evidence that neurointegration occurs in any of these cases. Thank you very much. I have to go back to Zoom. I want to stop sharing my screen. Just a moment. I will stop sharing my screen now, Manisha.
Yeah, sure, Dr. Hany.
Sure, but I want to see how. Stop sharing. Okay, yes, that's it.
Thank you, Dr. Hany. I think it was a wonderful presentation, and you gave a whole gamut of options available to us when you have a failed, macular hole surgery. So I would now request the panelists if they want to come up with some discussion points. Unni, would you like to show your video right now, or do we take it after the discussion? I think Dr. Unni also wants to share one of his interesting videos. Maybe Unni, you can show it right away, and then we can have a discussion together.
Okay. So thank you for the opportunity, Manish. I mean, this is probably, I was wondering which section this comes under, because we've had the whole gamut on the discussion already. So what was interesting is that I'll just show the video first and let's see how it works. It's a very small video of a small technique that we were looking at. It's been a collaboration with one of my colleagues, Dr. Ashok. And this is, I hope you can see the video. Unlike the raise a small rotational tongue flap. So at the edge of we take a vertical, not detach it completely. It's a rotational tongue flap. When you have this much, you can just position that into the macular hole without using a free ILM technique, and surgery becomes easy. The point is that you can also position it under air. So once you just have to raise a flap like you see over here. You can see the flap coming down. The edge of the ILM is lifted, it is turned, and it is pushed inside the macular hole. And it seems to be, we've done a few of these, and it seems to be a little bit more easier than a free ILM flap. And you have control. You can do it both under PFCL, you can do it under air and under fluid also, and then do an FG. So I'll just stop the screen share over there. Yeah. So we've just tried to write up a series of 5 cases, and it's gone for publication, and we call it the rotational tongue flap. It's been done previously, but it's been done for persistent holes. We've tried to use it as a rescue technique for a lost ILM flap. And it seems to be a very simple modification that can be used.
So it's a sort of a pedicle flap.
It's a pedicle flap. It's a rotational pedicle flap. And it comes from the edge of the ILM, and it can be done as I said, as a rescue technique when you've lost the, maybe something that can be tried before a free ILM graft.
It's definitely an interesting technique, and probably the pedicle would keep it in place more than a free ILM graft, as you said.
Yeah.
But sometimes the ILM is very friable in these cases that you cannot raise a larger flap. Did it work in all cases, or?
I think in the 5 cases we were able to raise it. It's the only problem is that if you have to lose your inverted flaps, you lose them early in surgery, not after you enlarge the. You better lose them early in surgery, not after you enlarge the entire ILM peel.
Yes.
So it was pretty okay for us in those cases, yes.
And do you do it under PFC or fluid in these cases?
This can be done under fluid itself. All you have to do is raise the flap. You can forget about the flap till you do the fluid air exchange. When you do the fluid air exchange, it naturally gravitates towards the posterior pole, and all you need to do is a little bit of tucking in the end.
Okay. Very interesting technique indeed. That's a nice one. Congratulations.
Thank you.
MPS, I think you had a comment to make for the first case as was shown by Dr. Hany.
Yeah, thank you, Dr. Hany, for a wonderful lecture once again.
Thank you.
It's a pleasure listening to you all the time.
Thank you, Dr. Shanmugam.
I was wondering if the first case we could have managed just with the outpatient fluid gas exchange prone positioning, because the hole was quite small and the margins were little swollen up with the cystoid spaces. There's a possibility it may have closed with just an FG.
It is possible in some of these cases that you do a fluid air exchange, but it also depends on the clinical setting. I mean, sometimes the patients will not tolerate another failure. So you are trying to maximize the chances of closure from the first surgery. But as you mentioned, I have done cases in which simply I have went inside the macular hole with a 41 gauge needle, aspirated the remaining fluid inside using suction, using the silicone oil pump, and simply by massaging the edge of the hole and fluid gas exchange. This can work in some cases in small holes as well. Yes, it's a valid point.
Dr. Hany, do you think that integration would be possible if the graft is taken closer to the posterior pole?
Integration of the graft, you mean?
Yes.
I don't think there is any possibility of neural integration at the present time. I mean, we do not understand how this would happen. You have probably to use some chemical mediators to promote the growth of nerves, so that both tissue can again unite. But at the present time, there is no such evidence. I mean, on the contrary, maybe Tamer Mahmoud has reported that taking the graft from near the periphery includes more of the stem cells of the retina that can allow better visual results and integration. But currently, I don't think this has been proven at any point or in any study.
Okay, I think there are two groups of how to use the autologous graft. One uses it tucking it in the subretinal space, and the other is the overlay technique. Do you find any difference in either of these, how they would work differently?
No, I did not find any difference in any of these techniques. In some cases, I mean, mostly it depends on the operative settings, actually, because in some cases, the graft would not be stable over the surface of the retina. So you have to tuck one end under the macular hole in order to keep it in place. So in others, maybe you can place it, as you have seen, over the surface of the hole and it remains stable. In visual results, I did not find any difference between both groups. But one interesting technique that has been reported is that you do it under perfluorocarbon and you leave the perfluorocarbon inside the eye for 2 weeks. And the idea behind it is that the oxygen tension inside the PFC is much higher than silicone oil, and therefore it allows better oxygenation of the graft in place and better taking of the graft. And in this case, you leave the patient supine all through for the first few days. He doesn't have to do a face down positioning or anything else. So this is a very nice modification, probably introduced by Steve Charles. And I adopted it in 2 cases and it worked. Leaving PFC inside the eye for 2 weeks is really good. And it doesn't cause any reaction, actually.
No, we've used it for GRTs also, where the patient cannot position. And you can leave it up to 2 weeks
yes.
without problem. Yeah.
I mean, we should look into a short-term tamponade using perfluorocarbon. It's very interesting in inferior detachments, in recurrent detachments with PVR. And what's more interesting, I have applied it recently in cases of endoresection of choroidal melanomas. Because in these cases, the step of doing PFC silicone oil exchange, usually you get bleeding, visualization is difficult, and so on. So my surgery ends by filling the eye with PFC. Even if there is bleeding, I go after 2 weeks, wash it very simply with the PFC. It does not clot in the presence of PFC, and then inject silicone oil. So I think we should modify our thinking about short-term tamponade of PFC. It's really a valid technique.
Okay, good. Thank
And
you.
Dr. Hany, any experience with the technique described where you make radial incisions for these kind of holes?
No, actually, I did not do it. I believe that's very traumatic in these cases. And in presence of other options to bridge the tissue defect, I don't think we should do these radial retinotomies in the macular area. I think this was reported by Carl Kleiss several years ago.
And if I was to compare both the techniques, one is the AMG graft versus the full thickness retinal graft. I'm sure both of them do cause an anatomical closure. But what about the visual improvement? If I was to compare both the techniques, because I just have the experience of doing 1 or 2 cases with full thickness retinal graft, even though it's a good closure anatomically, but the visual improvement is hardly there. So, I mean, what is your experience with both these techniques?
I think autologous, the amniotic membrane graft may offer even a better potential in these cases. Simply, maybe it contains more growth factors. It allows better survival of the surrounding photoreceptors, and in addition to providing anatomical closure. If we consider that in both techniques we are using a plug to close the defect, then I would consider that taking an amniotic membrane graft and putting it inside the hole, serving the same purpose, would save me doing another hole in the retina and achieving the same effect at the final.
So I have a question posted by Dr. Prachi Gaurav, who says that if you have a persistent macular hole where the edges are pretty much swollen with edema, and if you just inject IVTA, would that serve any purpose of closing the hole?
If I inject what?
Intravitreal triamcinolone.
No, I mean, what would it help? I mean, simply the edema only. I mean, the effect of triamcinolone is even temporary in these cases. So no, I mean, this is not a valid technique. You should look if there is residual ILM or not in these cases to close it. If not, then we should resort to other techniques for closure of the hole. As Dr. Shanmugam just mentioned, that we can even use a fluid air exchange or gas and aspirate the fluid in the center of the hole.
And there's another question from one of the delegates that if your patient cannot lie prone, what would be the best option for such patients? Like if you're having a fat, obese, an obese person, a patient, very difficult to maintain a prone position. What would be your recommended technique for that?
I would leave the PFC inside the eye and leave him in a supine position. This would be ideal for the patient, actually, in these cases. And go after 2 weeks and then remove the perfluorocarbon. Probably by then the hole would be closed.
And why would you like to keep it for 2 weeks? Won't 1 week serve the purpose? Because here you're not really looking for the uptake of laser or anything like that.
Well, you're right. Maybe 1 week would be enough. But I think leaving it for up to 2 weeks would make me more feel secure in these cases.
Right. Are there any comments from any of the panelists?
I have used retinal transplants when there is a recommended retinal detachment with the macular hole and subsequent, like we have peeled the ILM earlier. So when I had to do a drainage retinotomy, I used the same drainage retinotomy piece to close the macular hole. And in certain situations when there is a HST, the posterior part of the HST, or rather the tip which is free of the vitreous, I use that flap also sometimes to close the macular hole. So this way you don't do another retinotomy to make that.
Another question also is, if you have a macular hole and a retinal detachment, would you drain through the macular hole or through a peripheral retinotomy?
I usually prefer to do a drainage retinotomy if there is a macular hole and a retinal detachment. So as I mentioned, if it's a very large hole, then it probably doesn't matter if you're draining through the hole or the periphery. But like if we have done the patient is a resurgery where we have peeled the ILM and the macular hole persists, then I would probably do a drainage retinotomy and use that piece to close the macular hole. As you very rightly said, each case is different. So based on particular case scenario, you would probably choose what is the ideal technique for that patient.
Yes.
Dr. Mahesh, sir, regarding just a question, even though we know that the retinal tissue is just a scaffold, the taking retinal tissue of a detached retina, would you think the viability of the retina would be less than the viability of taking it from an attached retina?
We really don't know, because even a detached retina functions, right? Even if a macula off detachment, once the retina reattaches, it starts functioning. And again, like Professor Hany mentioned, we still don't know if the retina which we are putting at the macular hole functions, though there are conflicting reports. For instance, if you see Dr. Dilraj Grewal, if you speak to him, he is still not clear if it functions, but there have been MFERG reports from Rupak from Calcutta, where he thinks that there is some improvement in the MFERG and there is some improvement in the multifocal fields and things like that. So it's still not clear whether it's functioning or not.
MPS, we cannot hear you. Probably you have an unstable net connection. Any other comment from any of the other panelists? Because these persistent macular holes is always a problem. I mean, you really have to think hard what would be the best technique to be dealing with them. So I think Dr. Hany has beautifully showed all the options which are available in our hand. But sometimes it becomes a little difficult to take a call that which one is going to work the best. Yeah, Dr. MPS sir, you wanted to complete your statement. We couldn't hear you, sir.
I didn't know where I was actually. Yeah, now Unni was asking about like whether you can use the detached retina or not. I was trying to say that like I don't think it makes much of a difference because even a detached retina starts functioning subsequently when we reattach it. So like it actually, if it's to act just as a scaffold, it doesn't really matter. But if it's going to function, which is still unclear to us, then it may matter, but I would expect that like it's not too much of a concern.
I would like to add also that would it make a difference the orientation of the autologous retinal transplant or even the amniotic membrane graft? Would it make a difference? And are we really capable of knowing the exact orientation? And as we have seen with Sangeet, it was very difficult, this unfolding. I mean, it may have turned upside down or so, but would it make a difference? In your opinion, Dr. Manish?
The retina, I don't think it's too much of a problem. Like you yourself showed, you just drag it under the PFCL. I think we are able to make the orientation in place. But the question comes whether we are just using it as a scaffold or we are expecting the retina to function. So I would probably prefer to put it in the correct orientation as far as the retina is concerned, because in case it functions, then we don't want the photoreceptor on the top. And
yes,
probably that's how it is.
Because
but like amniotic membrane, I think the Stanislaw's group has shown some evidence that like it is better to put it in the proper way or something like that to do with the growth factors or something like that. But again, like I used a dried membrane, so it is very difficult to make out which is top or which is bottom. So amniotic membrane, I probably wouldn't make too much of a distinction, but retina, I would probably put it in the correct way it is.
Yes, because in some reports by Tamer Mahmoud, that in cases which had macular degeneration, he was turning it upside down so that the photoreceptors are in the graft are facing up, so that maybe they function even in this part. So, I mean, we have quite variations of this technique, and I think there is still a long way ahead that we know exactly its potential in the future.
What about using the lens capsule? I mean, how would you rate that?
I would rate it as the ILM, I think. I mean, it's, but I don't have an experience with the lens capsule. I did not try it in any of my cases. But simply, it's like an ILM. I mean, it's a non-functioning tissue. It does not contain growth factors. It does not contain any potential that would improve vision. It's simply a plug.
I think MPS sir, you have experience of using the lens capsule.
Yeah, once again, it's extreme cases where there's a recurrent hole, where we need some tissue for scaffold. So if the patient is undergoing a cataract surgery, and I would use a little bit of the anterior capsule, which the cataract surgeon has removed. And in certain situations when the patient is a pseudophakic, I have taken a little bit of the posterior capsule as a graft and put it there. Again, if ILM is not possible, if it is not there, then you can use any of these tissues and it works as a scaffold.
So would you avoid a trypan blue staining if you are planning to use the lens capsule for filling up your macular hole?
I don't think I've done too many to comment on that with certainty, but yes, like our cataract surgeons hardly use Trehan blue unless it's a total cataract. So in that situation, if it's a total cataract, like probably it'd be a primary surgery and you may not need any of these.
Trehan blue is, I think, much more safer than BBG. I think the lesser concentration even before we had the BBG into the market, Trehan blue was used, but it was shown to be even less toxic. And regarding the
problem is
yes,
the problem is for us to see inside. Sometimes the surgeon uses so much that the endothelium also becomes blue and you can't see what's happening inside. That's the only issue.
Anti-lens capsule is quite stiff. It's very easy to handle. Posterior capsule is slightly more thinner and needs a little bit more finesse to use actually.
So I think we are done with the discussion and all the questions. I don't see any more new questions coming up. So I really want to thank Dr. Hany for his wonderful presentation, Unni for your interesting medical graft, and all the panelists for this wonderful discussion. I'm sure given a lot of tips for, being very persistent with macular holes which have not closed on the primary surgery. So thank you so much for joining, Dr. Hany. I really appreciate your time.
Thank you, Manisha. Thank you very much.
Thank
Thank
you
you,
for the
everyone.
Wonderful session. Thank you all.
Thank you, Pramod.
I will just request Dr. Rahul to close the session for today.
Good afternoon, everyone. I think it was excellent bypass, excellent surgeries, excellent videos by Hany Hamza sir and everybody.
Thank you,
So
Rahul.
on behalf of Dr. Shroff Charity Eye Hospital, I take the opportunity to thank the master surgeons, Shobhit sir, Dr. Sangeet sir, and Dr. Hany Hamza, all the panelists from all the sessions, our IT team, our biomedical team, Zeiss for their constant support. They were all here full time with us for the past few days and helping us out, and Alcon for their continuous support for Retisurge Live. I hope that we continue this tradition of first Sunday of every March, every year as a Retisurge Live conference, and we continue this every year. So thank you all for your wonderful, I think it was by far excellent. So thank you all for your making it here.
Thank you very much.
Thank you, Rahul. Thank you.
Next time we will remember to keep lesser time for live surgeries if we have.
Yeah, I think Shobhit sir just took it away. First ball sixer. So
stay well, and thank you so much all the people who've joined us today for the conference.
Bye.
Thank you.
Thank you.
Bye-bye.
Bye.
Thanks. Bye.
thank you, sir. Thank you, Trehan sir.
Bye, Rahul. Nice